symptoms. So palliative care kind of started in oncology clinics, and we are there for like symptoms as people get their treatment. So the big symptoms we manage are cancer pain, nausea. We talk about bowels and like stooling a lot. So these are some of the bowel medications. We talk about anxiety or mood issues or anything that's coming up that might be affecting quality of life. And then we coordinate home services. And of course, we support the entire family. So just back to hospice, because we are experts in like what hospice provides, and people who do that palliative care fellowship can also go on to work as a hospice physician. So a team on hospice is actually really big, and it includes a physician, a nurse, somebody to come bathe the patient 2 to 3 times a week. It includes a chaplain, a social worker, volunteers, and then the best part is a 24/7 hotline, as well as equipment that is then provided in the home. And people generally stay home and they don't go to the hospital. Um, and hospice can occur in the home, it can occur in a nursing home, in the hospital, or even in a hospice home that some communities are lucky to have. So I think I was told.
Oh gosh, sorry. My headphone came out. Okay, can you hear me now?
Yes.
Okay, perfect. Sorry. So some key skills, regardless of the specialty you end up in, I'm not expecting everyone to end up in palliative care, but even whatever you decide to do later on, these are some key skills that I think sometimes get lost in translation or over time. But just always introduce yourself. Like, never presume that somebody remembers who you are, even if you've actually already met them. Just always introduce yourself and your role and everybody else around there, and check the relation of the people you're talking to your patient. Always use a medical translator if needed. And if it's a heavy conversation, prep the translator. Let them know, hey, this might be kind of hard. So just, bear with us. Check the relation of the person sitting there to the patient. Do not presume that that is a spouse or child or anything. You never know. And a very big one is to always check the understanding of your patient. So I always start after my introduction of like, tell me what you know so far, or how do you share everything that's going on with other people? Always like review clinical information in very simple terms. People have no clue about like our anatomy, or I remember during COVID having to explain that there's like two holes at the back of the throat, one for a breathing tube, one for food. And so always being super clear, not using medical words for your patients can take you very far. Also provide like clear options, but don't pressure people to make decisions. I usually present things in like a 3 pathway approach of like the first pathway is doing everything, like all medical treatments. The second pathway is a more limited approach, like things that are, maybe not as aggressive or intense. And then the third is focusing on comfort. So I usually present those kind of 3 options with the key intervention in mind. And I never put pressure to decide in that moment. I just give like, okay, you all talk as a family. I'll come back in another day or so, or hours, or whatever time frame you have, and then follow up. And be very clear with what your follow-up plan is. Okay. Are you guys with me so far? Good. Okay. So some other key skills. So just always think about like, how would I want my loved one to be treated, right? There's like I've been the recipient of some really questionable medical care, and you're like, that's how you're talking to me? Just treat others how you'd want to be treated. But at the same time, and especially with what we do in palliative care, it's not your role to take on their sadness of someone's situation. Like, they're dealing with that. And yes, it may be sad and hard, but you really have to work on separating your emotions from that. Otherwise, you will burn out, and then you won't be there for all your other patients. Um, so I just think that that's like something we don't really talk about enough in medicine. And so I hope even if you think about that early on, you can continue that along your time. Don't rush into clinical information. Like I said, always check someone's understanding. And if you have a hard case, like, debrief it with your team. Usually people in your same like group or a mentor, they're always willing to just like sit down and chat about what happened, because these things can be really hard. This is an app here called Vital Talk, that is a key communication skills training that we use. I think everyone should go through it, but It really helps you like lead family discussions and highly recommend it. I think I'm not sure if the app is free. I'm pretty sure it is, but it gives you like guidelines on how to talk with people. Um, yeah. Okay, so a typical like clinic case in palliative care. So again, we see people in the clinic, we see people in the hospital, but this is kind of a clinic scenario. So a 75-year-old patient with a new cancer diagnosis, but she's really unsure if she wants to do treatment. She's like, I've had a good life. Like, I don't know. So we follow along in palliative care. We talk with them about their goals, their wishes. This pink form on the left is called a pulsed form. If somebody does or does not want aggressive treatment like CPR or whatever, we fill that out. If their goal is to not be in pain, we manage their pain. If it's to be able to walk better or whatever it may be, if they just want to go to the beach again, then of course we support them doing that. But we always keep an open discussion of like, if your treatment is unbearable, we will stop and we will transition to hospice care. And on hospice, you cannot get this life prolonging treatment. So that's kind of the junction in the US. For those who are in other countries, hospice and palliative care are a bit more simultaneous, but in the US, it's very split. Okay, so a hospital case, of course, can be a bit more intense, more surprising. We have a 65-year-old patient with like kidney failure, liver failure, a severe infection, and now he's on a breathing tube, and there's no family right now. Like, what do we do for the guy? Um, so there are a lot of team members involved, and there would be, a social worker to kind of find the family. The nurse is doing the day-to-day care. The ICU doctor is the one that's like obviously doing all the life support, and they should still talk with family. And then a GI doctor, they all focus on like their own organ. So GI for the liver, kidney doctor for the kidney. But palliative care doctors come in and they talk about the big picture. They might set limits to the care, like, okay, maybe we continue the breathing tube, but we don't do like dialysis forever because dialysis is a whole other big intervention. And we support the family. We often have meetings like what you see here on the right in a separate waiting room and let people share their emotions. I've had people with young kids to middle-aged kids to like much older adults. And these are hard conversations, but they're so important to have so that we can match the care we give to what a patient wants. So in your career, you're going to see thousands of patients, and it's such a gift to be able to provide medical care for people. But always think about what they want, not what like you think they should want or what medicine says they should want, because everybody is different. And so sometimes it's like being brave, being the one who brings up like, hey, is this really what you want? I'm just checking, because we don't want to be pressuring people to get things they don't want. And I know that was a bit quick, but I remember I was in the ICU and I had a patient who was on dialysis. So dialysis is a kidney replacement therapy, takes out your blood, filters it, puts it back in. And he was just done. There's so many side effects with that. And he was developing very, very severe wounds. They were so painful. Even to do basic wound care, he needed so many pain medications. And he was done. And the resident that was there, or maybe a med student, was just like,
아, 이거 아이폰이라 모르겠네. 이거 원래 있었는데. 오리오.
oh, sorry. Okay, well, yeah, they were like, isn't it wrong to not continue dialysis? But that patient was done and they have the right to make, like, they have autonomy if they can make decisions. So it's not our role to push people on medical treatments forever. We really need to ask people what they want. And so I think hopefully that learner like really reflected on that and like was less afraid of bringing up these conversations of talking with people like what is important to you at this stage. Yeah, so I hope that makes sense. I'm excited to hear what kind of questions you all have. And again, you don't have to figure it out right away. So, okay, let me,
Yeah, thank you so much, Dr. Ra. I can
yeah,
let you know who has their hand raised and
okay,
kind of guide
perfect.
the questions from the chat. Um,
Yeah.
so the first hand that we have raised is from Kevin.
Hello, it's nice to meet you. So what would you say is, so what would you say are more like different approaches to talking with patients without going too hard on them.
Yeah,
Like
I
as
mean,
you mentioned in the slides.
yeah. So I think I mean, I have very similar conversation styles with every patient. Like I come in calmly, I introduce myself, I check, introduce, like make sure they introduce themselves and check in. And I think it's like sitting down can make a big impact. I'm very tall, so like it's someone's in a bed, you're hovering over them quite a bit. So like getting a chair, sitting down, asking if they're okay to like talk for a little bit, and just like being kind. I know that that sounds really basic and it's like, no, what's the key skill here, lady? But it's truly being calm, collected in yourself, having done like a thorough chart review so you know what's going on, and giving them concrete options, because oftentimes in medicine we're so like flowery, oh no, you could do this, you could do that, but people don't want to hear that. They want to know like, what is option one, what is option two, what is option three. And that's why I typically always frame my conversations in that three pathway approach of like full, are you somebody who would want everything that would include CPR, breathing tubes, or are you somebody who wouldn't want that? You would want things like fluids and antibiotics, or but not the, not the intense stuff. Or are you someone who wants to be comfortable and focus on your care at home and not get all of this? And usually that guides me. It's kind of like motivational interviewing of seeing where someone's at before you jump into the nitty-gritty details.
Awesome. Thank you. Dr. Earl, I just want to
Yeah.
let you know your Canva slides, like we can't see them. I think it's on a
Oh,
different.
okay. Oh, oops. Oh gosh. Sorry. Um, I changed the, oh wait, here we go. Maybe the view. Which one would it be? Gallery?
I think you go back to
Sorry.
your Chrome extension.
Oh, okay. How's that?
There you go. Perfect. Yeah.
Oh, okay, perfect.
Okay.
Okay.
Perfect. All right. Thank you so much.
Yeah.
The next question is by Samira. Samira.
Hi, I just wanted to ask, what would the procedure be if a patient just doesn't want to comply with your guys' support?
Yeah. So complying is a little different than like saying they absolutely don't want to, because you have to assess something called capacity. So capacity is like a patient's understanding of like do they really know what they're talking about. So there's four components to capacity. One is they understand, two is that they appreciate, three is they can reason, and four is they can express. So the acronym is UARE. So first you have to assess if someone has capacity, because if they don't, then they can't really make decisions for themselves. So let's take it back to that, a guy who doesn't want dialysis. So when people are confused, they don't want everything, right? And so if they do not have capacity, then, unfortunately, their decisions are not really the right answer. You have to then check with the family. Now, people can have limited capacity where maybe they can tell you, I want Bob to be my decision maker, but I don't know about the rest of the stuff. So then Bob is your decision maker and you would talk to them. But yeah, the kind of the pathway when we meet someone is, are they confused or do they have capacity to make this specific decision? If it's unsure, like we can make a capacity assessment, or psychiatry can even make a capacity assessment, and then we go from there. If somebody is like so out of it that they can't make a clear decision, then we rely on what the family wants. If they do have capacity, then it's up to them, and we bring up those same questions of like, well, what do you want at this stage of life? Is there, let's see, I would love to be able to see the faces because now I can't see
Yeah.
anybody.
I think if you go back to the Zoom, like, and you can
Oh,
unshare your screen if you want,
oh, okay,
and
okay.
come
Sorry,
back on. Yeah.
okay, perfect. Let me, sorry.
No worries.
Oh, it stopped share. Okay. I'm sorry. Okay, go ahead.
Are you able to see everyone now?
Yes, now I can
Yes.
see people.
Okay.
Thanks.
Perfect.
Yeah.
Yeah. All right. The next question is from Ramisa.
Thank you so much for your presentation. I mainly had to ask about two things. So firstly, I was wondering what the youngest age would be of someone who you've treated with palliative care.
Yeah, no, great question. So palliative care is actually available for kids. I actually only see adults, but there is a whole field of pediatric palliative care. So I even had a friend who had a baby and they were in the NICU, and there was a palliative care team there to support them. And they said it was the best experience because someone was there to just listen. I personally have treated, 21 and above. And that's just because like I chose to just see adults, maybe 18 to 20. And those were patients with like a cancer of the bone or things like that. And sometimes we see people who they have an illness, but they're not actually like terminal. They're getting treatments. Like think of cystic fibrosis. So that's a disease that used to be terminal, but now there's so many treatments that people live a lot longer. I had a young patient with that, and she just kind of wanted someone to like talk to or regain some control because that was getting lost in all her hospital stays. But yeah, so people who do our fellowship, they can, if they're pediatric trained, they do the 1 year fellowship and they can go become pediatric palliative care doctors. Pediatrics is very different with hospice. You can actually get um, people who it's called concurrent care. So I mentioned for adults, you cannot get treatment with hospice to prolong your life. For kids, you can. So you can continue chemotherapy and get palliative care. And then if they think you're 6 months or less, you can get hospice as well.
That's very interesting to know. And I was also wondering what your transition was like going from the UK to then integrating yourself into the whole US like
Yeah.
practice.
Yeah, no, great question. So I think the UK is so different, but I do think we have a higher emphasis on communication. That was like ingrained in us from day one. But like I mentioned, it's very hard to come back. So I finished medical school and worked for a year as what's called a junior doctor. That gave me a lot of traumatizing experience to set me up for residency. Like truly, it was so hard. And there is like in the US, as a resident, it is hard. There's a lot of hours, don't get me wrong, but you are not doing things like phlebotomy. You're not pushing your patients around or what we call like scut work. In the UK, you're doing all of that stuff. And some of those things are just so like degrading. It was just really bad. And so um I was very well prepared for my residency because I had been through that and really gone through like the junior doctor life for 2/3 of a year. Um, I can't say I recommend it, but yeah. So yeah,
Thank you.
yeah.
Perfect. The next question we have is from Kelly.
Hi, it's really nice to meet you. Thank you for the presentation. I learned about a lot about the palliative care. So my question is that you mentioned that you do some like symptom management. I'm wondering if you can elaborate on that. Like, do you just prescribe like medicine?
Kind of. So we are like experts in symptom management to get people to live a better quality of life. So we think like outside the box and in the box. So in my toolbox would be medication. So for pain, we use a lot of opioids. So I feel like I didn't truly understand opioids until I did my fellowship. And that's both in the clinic and in the hospital. Um, like in medical school they don't really teach you about how to like use every single opioid, and I feel like much more confident now. We also use non-opioid pain medications like gabapentin or whatever else is needed. We manage constipation, of course, so it's like you really have to get comfortable with your patients talking about their bowels. Like you can't like there's no way to dance around that. But then sometimes patients need things that we don't do. Like I don't do procedures, but we could connect them to interventional radiology so they could get an injection, or pain management. They could get an injection to really help their pain and live better. So we think about how can they live better? Like what's important to them at this stage? Some people they don't want to go get an injection. That's not in their goals, but others are okay with it. So we spend time and we have follow-up appointments and talking with people about what matters to them and then match their treatment plan to that.
Okay, thank you so much.
Yeah, sure.
The next question we have is from Young Jun.
Hi, thank you so much for your presentation today and for taking your time. Would you say that palliative care is related in any way or involved with the field of bioethics?
Yeah, so definitely. We're kind of like cousins. So it depends. Every health system is a little different with bioethics. When I worked in Pennsylvania, our system had three like actual bioethicists on staff. So they were people who got their PhD in bioethics. They were not doctors, they were bioethics people. And they know the law very well. Now, in my current hospital, the bioethics committee is made up of like doctors and people who just have a special interest in bioethics. It's actually so interesting how each state has their own rules. And even between Pennsylvania and California, there's a whole different like setup and hierarchy about a lot of things, like who's your decision maker if you're confused. It's very interesting. But we are related, but I don't call myself a bioethics expert by any means. I think I would need like another formal training to do that. And I kind of prefer if other people do it so that I have someone to call, like if I need help. So, yeah, but we are very closely related and it is a great field. I mean, they can make a very big impact. Yeah.
Thank you so much.
Yeah.
The next question is by Yukta.
I thank you for your presentation.
Sure.
It was
Yeah.
really helpful, and I learned about a field that I didn't really know about.
Yeah, that's
And then
great.
my first question is, you said that you did like family medicine, and I was just wondering like what led you to choose family medicine
Yeah.
and like overview.
Yeah, so I always I mean, I have a lot of role models in medicine. A lot of my family is in healthcare, and my sister had done family medicine, my brother's an ER doctor. You know, it's like we all did it. But I liked seeing everything. Like I never wanted to just limit myself to a specific population. I'm not really a procedural person. Like I don't like being in the OR, and I think the biggest thing when you're determining a career is to figure out, do you like surgical specialties or not? Like I like talking to people and I get very itchy in the OR with all that stuff. So like for me it was very clear I was not going into the OR. But family medicine is so wonderful because you just not no 2 days are the same. Pediatrics is also amazing, but if you want to think about your career long term, you want to look at like the financial compensation models, and family medicine has a lot more funding behind it than pediatrics. So I also again like seeing adults. But those are some of the things that led me to apply to family medicine. Now, the other reality is when you go to school abroad, you are looked at a bit differently, even if you are American. So you cannot expect to match into neurosurgery or derm, like all these very competitive specialties that the US people are going to get and apply for. You can, I'm not saying never, but I was very practical in that I picked primary care because they have a very high IMG match rate, as well as internal medicine and other primary care fields. And all of that data is available online too. But yeah, I truly loved family medicine. I thought that I wouldn't specialize, but then I kind of realized there are so many great family medicine doctors, and there really were not that many palliative care doctors. So when a mentor mentioned I was good at it, I kind of dove right in, and now that's my only thing. I don't practice any more family medicine. Well, I mean, like formally. I feel like there's so much family medicine in palliative care, to be honest. I hope that helps. Yeah.
Thank you. The next question we
Yeah.
have from Rachel.
Hi, thank you for your
Yeah,
presentation.
of course.
So my question is, what is the typical timeline of receiving palliative care? Like, when would you step in for the patients?
Yeah. Do you mean in the hospital or in the clinic or
Either
both?
or.
Either. Okay. So it really depends on who is putting the referral in. And ideally, people see palliative care early on in their journey. So let's say they have the cancer diagnosis, maybe they're just starting treatment. They could see palliative care pretty early on. And then we could space things out, or if they're having symptoms, we just keep seeing them right away. So that's the ideal. Now, that relies on the other doctors to place the referral. And just like how you guys are saying you've never, like, this is new for you, sometimes it's actually new for other doctors to hear about palliative care. It's getting better, but some of these, like, people who they never learned about it in their training. So I had worked with like a 75-year-old oncologist who, it took a while for him to understand what we do. because he often did that same kind of care. But ideally, it's earlier. There are actually studies. So in 2008, there was a very big study out of Harvard with a woman named Jennifer Tamel, and she did palliative care clinic interventions for people with lung cancer. And it was only like the intervention actually extended the life expectancy of those patients for 2 months. And because that even led to an increased survival, improved quality of life, decreased cost of their care, there were so many different things it showed that really led to palliative care like being propelled forward. Now, in the hospital, it can really vary on what's going on. Some people in the hospital we get palliative care on early, but like truly in my mind, if you're already in the hospital, like there's something that's led you there, you could benefit. But other doctors sometimes they want to focus on like full, doing everything and then they get palliative care. And so sometimes we are invited into the conversation very late, and that's not ideal because now we're like a new person talking to this family, and it would have been better to meet them earlier. So ideally in the hospital, if somebody has multiple like serious illnesses and the other doctors think they're not going to be like they're not going to make it, it's very helpful to get palliative care involved. I usually see patients for about a week or maybe 2 weeks before we iron things out, and then they may pass away or go home.
Perfect. Thank you. The next
Yeah.
question we have from Daniel.
Hi there.
Hi.
So this is a different style of question, but I was
Sure.
wondering in the US how like affordable palliative care is for
Yeah,
patients.
no, great question. I think so important to think about cost. So palliative care is just like if you saw another specialist, like if you saw cardiology or, whomever, you have what's called a copay. So you would typically have to pay your copay. Now, palliative care is changing because they know, like big healthcare executives realize palliative care can save money down the line. Some places will just do it for free to get that copay like waived because it'll save money for them later on. Hospice is totally free. All of that stuff I mentioned on that list, totally free of charge. So people may think, oh, I can't spend on like one more doctor, but actually it's usually the same as seeing other specialists, if not less.
Okay, thank you.
The next question we have is from Manuel.
Hi, thank you for your presentation.
Yeah.
I was just wondering, you mentioned trying to keep their story like separate from yours. How do you
Mhm.
manage that? Because I thought that would be like
Yeah.
a very hard thing to do.
Yeah, no, great question. I have a commute, so I drive like 25 minutes. And I mean, I can't say that every patient story does not come home with me, but I think it's very important to like leave it at work. And I think that that drive kind of helps me separate my distances. When I previously lived like 10 minutes away from my residency hospital, I felt like it all just blurred. I have young kids at home, and like I have to be fully present for them. I can't like constantly think about all this stuff, but it's a learned skill. You have to be very intentional about keeping that boundary and that separation. One time I had a learner with me who was like really anxious about this whole thing because they're like, how do I manage? And we thought of different ways of one way is like when you're in the hospital or in a clinic room, you use hand sanitizer like when you walk in, right? Like you walk in, you use hand sanitizer, give yourself and be so present in that moment for that patient and their family. And then when you leave and you sanitize out, like leave it all there, and now you're leaving the room. Just focus on leaving your heavy feelings there because you have to give more to others, whoever that may be in your life. And so, if it's not being callous to that moment because you gave yourself you were so present there. Does that make sense? Again, it's a learned skill. It takes a long time. I definitely had moments that were very hard, but if you're finding that it's really hard for you, I would highly recommend, finding a mentor you can talk to, finding a therapist, seeking out employee support. Like your mental health is so important in this journey. And now I think we're kind of talking about it, but I can't say that everyone does. And so having the separation, again, the commute, all those things are just small tidbits, but like if you don't focus on your inner self, then you won't make it long term. So make sure to put in that work, especially early.
I
Thank you
love
so
that.
much.
Yeah.
I love that hand sanitizer analogy was
Yeah,
so
yeah.
thank you for that. Yes. The next question is by Liliana.
Hi, Dr. Rao. Thank you so
Hi.
much.
Yeah,
I really loved your presentation.
thank you.
And I was just wondering, let's say a patient was more resistant to palliative care and they were more kind of hesitant to like giving their all. Would you have a
Yeah.
consult like from a psychologist, or would you more like kind of step away from the patient?
Yeah, I mean, sadly, it happens a lot, right? Because people don't know what palliative care is. They think we're hospice. They're not ready. They're like, oh, I'm not ready for that. So it's really up to like who is introducing us to kind of hype us up. And then if somebody's not ready, we can't push it. That's not our role. And even if I talk to somebody and they're like, look, I'm good. Like, I don't want more people. That's okay. Like, I just move on. I don't take it personally because they're not at that space that they're ready to like hear or think about these things. And I can't force that. Sometimes people will kind of come around, of course we can leave information for them, but by me recommending like, oh, go see a psychologist, I'm not sure that would go well, but if the primary team did that, that would be a great option. Sadly, psychologists are not fully available in like all hospital or clinic settings, but they are becoming more and more part of our healthcare teams as they should be. So hopefully that changes. I think my goal, and this is even why I started a social media platform, is to just share the word of palliative care early so that whether it's the patients or their kids can kind of realize, oh, that is extra support. I don't need to be afraid of it. Let me get them on. Because truly, like palliative care people are the kindest, most approachable, like people to talk to. Nobody needs to be afraid of us. We're all like wonderful. So, yeah.
Thank you. The
Yeah.
next question is by Mukyoung. Mukyoung?
Hello. Thank you so
Yeah.
much for your presentation.
Sure.
I was, I guess, really inspired by this field of palliative care because, well, I've never heard of it before, but I thought it was really close to my interest. Because I'm
Mhm.
interested in psychology, and
Yeah.
I
Yeah.
just thought like I like helping people, so I just thought of like the combination of those two are really nice. And the question I had was also related to psychology and palliative care. In your education or like residency or
Mhm.
anything, do you ever have to go through like any psychological aspect of it when it comes to like like a class or like anything sort of
Kind of. And so I'm just checking, do you mean psychiatry or like psychology?
like psychology and
Okay, so in family medicine training, there is usually one person on your faculty who is a psychologist or like somebody with special interest in that field. So in your residency, you should at least get like lectures on the benefits of like therapy, the types of therapy, things like that. They do not do a good job of teaching doctors about these kind of things. It could very greatly be improved. Now, in the field of palliative care, we use psychologists a lot as our interdisciplinary team members. And for those who do psychiatry, that can even be one of the primary specialties you do before a palliative care fellowship. But yeah, there really are a lot of palliative care psychologists or oncology. I mean, oftentimes they're called behavioral health specialists, but yeah, in that realm, there's so many opportunities there. Such a lovely field, and people I've worked with have gotten their PhDs or, like gone so far in these things, and then are such a wonderful support for patients. But I usually like a hospital palliative care team, they don't really have a therapist. Not saying they never would. I think it's just really hard. Like usually that's kind of someone in the clinic setting.
thank you.
Yeah.
Perfect. The next question is from Emma.
Hi. I just wanted to ask if um if a patient wanted to go like one way with their care while the family wants to go another way, how do
Yeah.
you like dispute that
Yeah.
that
No, great question. Yeah, it happens sadly more often than you would think. And usually, so it kind of goes back to that capacity thing. So we have to assess the patient's capacity. So if the patient does have capacity, they can tell us what they want. They can tell or what they don't want. They are what matters. We would often then host or offer to host a family meeting with their family to iron it all out because we don't want like chaos and drama like that. It can definitely happen, but we don't want that. So we would set up a family meeting, or if support them and be like, if you want to tell them, we support you. We'll be here for you. Um, it does happen, but usually this is like an error of communication. And so once that's ironed out, people understand it more. And especially like when the family's otherwise healthy, but there's that one loved one who's very sick. They know what it's like to be the caregiver, but they don't really know what the patient's going through. So sometimes the patient just needs to have a voice again. And sometimes the opposite occurs too. The patient is like, no, no, I want to keep doing this and I want to keep living. But the family is like, oh, we thought you'd want to be comfortable at this point. So we have to just make sure everyone's on the same page. And that's where, being a calm communicator, like meeting patients where they're at and just everybody being open with their communication can go really far.
Thank you. The next question we have is from Dongha. Sorry for pronouncing your name wrong.
That's fine. Thank you, Dr. Rao, for your presentation. So I just wanted to ask, what do you think is something that every physician should learn from palliative care, even if they never decide to specialize in it?
Yeah. I mean, I would love if they truly like two things. The communication skill would be sitting down and calmly and checking their understanding, and like doing all those same communication skill type things. But then second would be referring to palliative care as extra support because we are also part of the medical team, but sometimes you have like ego involved or a lack of understanding, and I think that that's silly. Like it should be that we're all working together, even if that may be different than what I have like cardiothoracic surgery who I work with closely now, of like they are doing these like really intense things on very sick people, and that's great. But if they can bring us in as their colleague, it goes so much further. For if the patient says, look, I don't want this, then we're all on the same page and we're all aligned. So I just wish every physician knew about us would be great, but also knew when to refer to us. And then if they're not going to, at least communicate well. I know that's three things. Yeah.
Yeah, love those tips.
Yeah.
Those are great. Thank you. The next question is from Ferris.
Good morning. I really appreciate the time that you took to, explain this topic to us. I feel like it's very significant and kind of, something not talked about because of like the sensitivity. So I really appreciate about how insightful it was today. And my question to you is, how do you navigate patients who are hostile or uncooperative?
Oh, yes. No, great. Great question because like my safety is a priority, and if somebody is hostile towards me, there is a zero tolerance policy. The same thing goes for racism or rudeness towards me or my staff. Like that's just a no-go. So I think that healthcare workers need to talk about this more. I know that on the wall there'll be signs saying like don't be mean to staff, but that doesn't go very far. You really have to have very firm boundaries. And I had a patient who I think had like a personality disorder who had already kind of been rude to my team member and wanted us to prescribe a controlled medication. So now I'm the physician on board and I'm saying, no, sorry, like you don't need it. They flipped out at me. This was like a very large person. And the sad thing is, in the room, like there was the door, and then there was a patient, and then there was me. And that is really unsafe. Like we should be by the door so we can always leave, right? Instead, I was like I felt uncomfortable that this patient and their wife were there. I literally got up and said, I'm sorry, I think we're just going to have to end this relationship. I don't feel comfortable right now. And I just stood in the hallway and had my staff there. Again, my safety is my priority. Like I have kids at home. I'm not risking my life here, but and they left. The crazy thing was like my team member saw them by the elevator. They were like bawling in fake sadness. The moment they got outside the clinic, they were totally fine. And again, there are people with a lot of issues out there, but like it's not my job to fix it. I'm here to provide what I can provide in my toolbox. I don't get like, I'm sorry if I'm not doing what you want, but we don't have a therapeutic relationship anymore. It's done. And your health system cannot fault you for that. And then in the hospital, if somebody's hostile, it's also really strict. They put a thing in the computer system I don't think it happens to me as much because I'm not there, but the nurses, they go through so much. And if somebody is like physically or verbally aggressive, it will be on their medical record, like until another person like decides to, they all have to like meet and talk about it because it's just not unacceptable. So yeah, I think just always keep a firm boundary. There are some rude comments out there, and it's just no. Same thing on my social media. If someone says something rude, I'm just like block. Like I don't need to engage with that. I don't think we have time in life for negativity. So yeah.
I think boundaries are so important. So thank you for that
Yes,
perspective
yeah,
there.
yeah, of course.
The next question is from Fami.
Hi, can you hear me?
Yeah.
Hi, Dr.
Hi.
Nikki.
Yeah.
It was a great presentation. My question is, how are you as a physician make sure that you provide the right medical treatment while considering the patient personal values?
Yeah, and that's why you always have to ask their goals and values before you like jump into your treatment. Sometimes it's hard because patients are like, "No, lady, you tell me what to do." And I'm like, "No, no, you tell me what you want." And they're like, "Oh," because especially our older population, they're not used to like a non-paternalistic style, where I'm asking about what they want. They're really
Right.
not used to that. And so it's just kind of like it's an art, of listening before you speak and just being like, okay, well, tell me what matters to you because like I had a patient with I'm not sure if you've heard of something called Huntington's disease. It
Mm-hmm.
is like
Yeah.
a neurological, right? So they have like all these movements and that
Mm-hmm.
can even be from anxiety, from like there's so many things that go into this
Stress.
this horrible illness. And
Mm-hmm.
he just wanted to walk his daughter down the aisle. Like he really didn't care about anything else. And that was the goal. And so everything we did got him to that goal. And he was able to. Like we got his symptoms under control. We made sure he was like awake enough to not be asleep with all these medications that kind of keep you calm. We built a relationship so he was less anxious coming in to see me. He ended up moving to like an assisted living. Like we had to do all these different pieces of the puzzle to get him to that goal. But that was always in mind for me. It was not, oh, like, if he had pneumonia, like he didn't want to be in the hospital because then he might miss the wedding. It's like things like that. And so
Yeah.
trying to keep him out of the hospital, trying to keep him healthy enough or eating enough. And he didn't want a feeding tube. So how do we work with speech therapy? Like all these things to really support someone. And that is so gratifying. Like I think it's hard to kind of truly show to other people like how wonderful it is to provide this type of care for people. Oftentimes, when you think of like a GI doctor, cardiologist, they like see their patient and like, great, do your thing. But for us to talk about the whole person, the mind, the spirit, like all of the things for these beautiful moments, even if it's a sad scenario, is so wonderful. And yeah, I hope that no matter what field you all go into, you can still find that joy because that's what keeps you going.
Okay. One more question. How do you
Yeah.
maintain that balance between your work life and personal life
Yeah.
without getting burned out?
Yes, no, great question. So important. And a part of also why I chose palliative care, when I first went to the conference, I looked around, I was like, wow, everybody's so happy. And there's so many pregnant people here. Like I knew I wanted kids one day. And I was like, this must be a family friendly field. I can't say that at like some surgical conferences. So I knew that,
Agree.
not saying that you can't do it. Like there are some incredible women out there balancing surgical and mother like that. They're amazing. But I knew that that wasn't for me. So palliative care is, preaching about quality of life. So I made sure I had a good quality of life in my job. So I have always worked 4 days a week. And you have to just be open with your employer when you're doing your contract. So I know this is many years out for you guys, but just always remember your time is valuable. And I always have like a day off per week. I think I'd go nuts without it. And the same thing for family medicine or other careers. Like you can usually negotiate a 4 day work week and still be full time. So then you have your benefits. I literally always use my PTO. I don't like what are you gonna do? Like it's not gonna come with you when you pass away. So just use it. Our rule as a family was kind of to take at least a week off every 3 months. So you have like even if you're not going anywhere, just just be off. Like you don't need to work all the time. And so I think we all need to step away from this like workaholic mentality, especially in medicine, because having all your PTO buildup doesn't help you very much, apart from if you're saving it for your maternity leave, which is a whole other, debacle in this country. But, find like the wellness, find what brings you joy. Those people in your life, I'm still in touch with my friends from high school. We've gone through this journey separately and now come back to each other. And like, those are your close friends. Make time for each other. Like, nobody is passing away and is like, wow, I'm so glad I worked all those years. Like, that's not the goal there. Or I'm so glad I took that meeting when I was on vacation. No, you need to have time off. You need to have a life outside of work. Because at the end of the day, when we all do pass away, we're all replaceable. I moved for my job and I found my replacement who started a week later. Um, your family, who you are as a person matters so much, and like you're irreplaceable to those around you. So yeah, I can go on about all this stuff forever. Yeah. And I post a lot of that on my Instagram too.
Thank you. It was nice
Yeah,
speaking
of
to
course.
you.
Yes, of course.
Awesome, love it. The next question we have is from Adriana.
Hi, good morning. Thank you a lot for your presentation. I found it really insightful in palliative care, which I really didn't know about. But my question is, you mentioned in the beginning that you studied medical school in
Yeah.
London.
Yeah.
I think that's an opportunity I'd love to have, but there's obviously the whole thing with the licenses if
Yeah.
you want to come back and all of that. So I'd like to ask you more about that
Yeah.
process and how it was like and what you had to do.
Yeah. So, okay. So, I knew I wanted to go into medicine. I'm guessing all of you do too, hence you're here. Now, the appeal to go abroad is great, and these schools will try to take you to go abroad. Be very careful who you pick as a school, because if you want to come back to the US, I have seen, because when I did my last job, I was on the residency application committee. So I would see these random medical schools from like Fiji, wherever. They're like technically doing their rotations in the US, but they're like online for 2 years. Do not do that. If you want to go abroad, you could go to like an actual country and be an international student. And in London, I absolutely loved it for those 6 years as a student. Those were fantastic years. But coming back to the US, you have zero support from that country because, like, why would they care where you go? So you have to take your USMLE exams on your own, which is very hard. While in the US, they support you, like, because they want you to pass, of course. But let alone, you also have to take all your UK exams. So 2014 and 15 were very hard years of my life to take all these tests. Like, there's just so many tests. Now, if you are willing to take the risk that you could live abroad forever if you did not match in the US, then it's great. I have a cousin who is doing medical school in Australia that then has a 2-year like thing in the US. She's still early on, so I don't know what'll happen in her career, but she's willing to live in Australia. Like, she loves it there. Fair enough. So I think just really think hard about plan B if you don't match to plan A. And you probably need to really be realistic in that you need to pick a specialty that has a high IMG match rate. So you can see all that stuff online. The actual experience of going there was great. I mean, London is amazing. Of course it's expensive, but if you're able to make that work, so is school in the US. So like, yeah, and you don't have to take the MCAT to go abroad. They usually have another test. It may have changed by now, but I took something called the UK CAT, and you can only apply to 4 schools. You can't apply as broadly as you can here in the US. So for me, it was kind of like, oh, let me just apply, let me take the chance and see. And then I got in, and my sister had actually done the same. So I have a lot of family there. So for me, it was a very natural transition. The other thing that's very different in the UK is the exam structure during your time there. And places like Poland, India, very similar, where you don't have any tests like throughout the year. You just have all your exams in like May. And so I was not used to that. Like in the US, I felt like I just always had like a test coming up and I kept my mind going. There, I was like living it up in London and then like 2 months later had to learn for the whole year. That was very hard. And I even failed a test one time and that kicked my gears into motion of like, no, I really need to focus here. But it is a very different learning style. You have all the brightest minds of that country going to that school. They are not coming to the US. So like they're all staying there. So now you may have been your shining star in California or wherever in the US, but you're up against some like really heavy competition abroad. Yeah. So if you choose to do that, like I obviously did it and I love it, but the other like emotional aspect to think about is that those are such formative years of your life. Like that was my high school and my graduate school combined. So your friends become so close. So I have my closest friends now all live in the UK. So when you then I live in the US and my friends are like when you have babies or if a pandemic happens, it's kind of harder to see all your friends who are abroad and that's hard. Even though I love them so much, like it's different when your friends live across the world than if they just live in the country and you can go drive to see them. Yeah, I mean, I would just take it with caution and like don't pick some random school that's online. I was appalled that these places take your money. I would try to stay in the US if you can, or maybe Canada, but um, yeah, and of course, feel free to email me or if you ever have any questions, we can always connect.
Thank you. Thank you.
Yeah.
Thank you. The next question has from Elizabeth.
Hi, thank you so much for your
Yeah.
presentation. I was wondering, how do you help patients who are struggling emotionally with their diagnosis or conditions?
Yeah, of course. Lots of emotional support, lots of listening to them. If they need, like oftentimes things go into categories, right? Like they're either super anxious or they're very depressed. So we can use medications for those or get them connected to a therapist. They may have like spiritual or existential suffering. A chaplain can be really helpful in that point. And then oftentimes like our social workers can really help like iron out that emotional like everything, the tornado that's going on. And so we don't have to like take it all on. That's where we work as a team well to like have somebody who's an expert in doing that, like really go through it with them.
Thank you.
Yeah.
Thank you. The next question is from, again, I'm pronouncing your name wrong. I'm sorry. Akshpriya?
Hi, thank you so much for your presentation. I feel like I learned a lot. So I know you started off in family medicine and then transitioned to palliative care. I was just wondering what made you decide that that was a better fit for you.
Yeah, so I loved family medicine. Like it's so broad and you get to see everything. And then, but a part of me did feel like, man, I kind of like having a narrower scope. And so one of my mentors was like, wow, you'd be really good at palliative care because that's what he does. So he recommended I just go to the conference and I just loved everything I saw there. And I felt was like, oh, these are my people. And so that's what I just kept going and never turned back. But family medicine, or I actually thought at one point I would do psychiatry. And then I did my psychiatry rotation and was like, no, this, I don't know, amazing that people do it, but I think I took on a lot of that emotion and that was hard for me. But palliative care, I feel like I still get to be there for people at really crucial points of their life. It's just not like the psychiatric disorders, that's a whole other realm. And it's just really hard. But yeah, I felt like family medicine, I could still connect and I love the continuity, and palliative care still provided all those things.
Thank you.
Perfect. The next question is from Anna Marie.
Hello, doctor. Thank you for your presentation. I'm wondering, did you go to London because did you go straight to med school there? Because I know European systems are different, and did you do that for like to save time? Because like the whole doctor system here is like so
Yeah.
time.
Yeah, multiple reasons, but yeah, I mean, my like I think I knew I'd go into medicine pretty early, like at an early age, and then my sister had a friend who was British in San Diego where we grew up. So they had both gone to school directly after high school, and I could just see like how much fun they were having from my sheltered little life. And so I started looking into it, and I'd visit her and be like, "Oh, actually, this looks pretty nice." But then, yeah, in the UK, it's a 5 year degree. So you do 2 preclinical years and 3 clinical. I did a program that had something called a conversion year. So it had one more year before that where you could like just refresh your basic sciences and whatever. And that's just what King's College London provided. So I did that. And I'm glad I did because it got me like very comfortable living abroad and then started my medical school journey. But so that was 6 years. And then I worked for 1 year. But you're right, Europe, India, like they're all the same. And you don't have to do the MCAT. You don't have to go, undergrad and then med school. But um, yeah, I mean, sometimes I feel like I missed out on the undergrad experience because we lived in like where Penn State is, and it just looks so fun. So with like college sports and everything, but I appreciate the stress of applying to med school is immense. So yeah,
Thank you.
yeah,
Okay. Well, did a question from the chat. Someone
sure.
asked, I don't know if you've had this scenario, if this scenario is common, but have you ever encountered a parent who didn't seem to be making the best decision for their child? And if so, how did you go about that?
Yeah, no, great question. Thankfully, I have not encountered that. I think I feel like I saw that a lot on TV, like in Grey's Anatomy, but it thankfully has not happened in my life. But the question of capacity is, I think like each state has like their own age limit of how old someone can be to have capacity, and I think always checking like for age appropriate metrics of can someone make decisions because sometimes like I mean, I feel like I saw in the news one time of a parent who did not put their treatment or their daughter through treatment for a treatable cancer. And, if that's not the right treatment, then that parent would be removed as the decision maker and a guardian would be placed in. So the same thing does happen for adults if there's a patient without capacity and now somebody swoops in and seems to be making decisions for their own financial or weird benefits, then they could be removed as a decision maker. So that's where things like ethics come in. And of course, palliative care is there, but hopefully these things don't happen too much.
Thank you.
Yeah.
The next question we have is from Sarah.
Hi, thank you so much for your
Yeah, of course.
presentation. I was just wondering, like, what was your experience like coming back from Europe and like matching into your residency? Like, was it different? Like, how did you approach it?
Yeah. So yeah, I had to apply like pretty broadly and keep a very open mind that so I had like interviews random places I'd never heard of. Like I remember I was in the middle of Ohio, obviously Pennsylvania, Washington, like I was all over the place. Thankfully now it's a lot of them are virtual, but I was flying all over the country. So coming back was unique. I think especially when you've worked in another system like I had, nobody wants to hear all the time of like, oh, in England we do this and we you kind of have to keep some of these things to yourself. And adjusting to like the culture in healthcare, there is kind of a persona, I feel like, of the US medical resident with their like Patagonia jacket and like who they are. And that's just not me. Like I wasn't like that. In the UK, it's just really different. I picked up that doctor persona. But I think I gained so much clinical experience that I was pretty efficient and I was like open to learning and just no matter where you go or what you do or what background you have, just go into residency and your training with an open mind. And I'm like a social butterfly. So I would like connect people and just plan social events and be like a support for other people. And that doesn't always go well with your co-residents. Sometimes they can be a little like, why is she like that? But that's just who I am. So I just let all my personality aspects shine and that led me to a lot of success. So um but yeah, it is a hard transition no matter what you're doing. Even from med school in the US to residency, I think, people are like, sometimes they start and they're like already, taking on the burnt out persona. And maybe they are, but we're also, as the attending, you're like, well, we haven't done anything yet. So yeah, it's just, just go into everything with an open mind. Take care of yourself, of course, but you're there to take care of patients. Like you're there for a reason. So yeah.
Thank you so much.
Yeah, of course.
Yeah, the next question we have is from Ellie.
Hi, thank you for your presentation.
Uh-huh.
I feel like listening to your responses, I feel like you're very good at like keeping your boundaries. So I wondered if you've always had like the skill or like how long did it take you to develop this skill?
Yeah. No, great question. Definitely did not always have this skill, although I do feel like maybe younger generations have this skill earlier on than I did. Um, but no, I think it's just a learned thing. And then in doing this work, I think you really have to focus on coming up with your own boundaries of like what, and sometimes it's hard. And even in my own life, like sometimes I give a lot to my family or my friends and I have to like reel myself in. And so Yeah, I think it's like, just checking yourself and like, I don't know. I've always had very supportive friends too, so that kind of helps. I don't think there was like a key moment that I decided I need to have boundaries. I think it just developed over time. And in palliative care fellowship, we do talk about those things too.
Okay, and also like kind of related to that, I was wondering, you said you like see death a lot in patients. So like does that ever like really impact you emotionally, especially after you've built
Yeah.
like a long connection too in
Yeah.
fellowship?
Oh, of course. I mean, so the thing with like the actual death part in palliative care is I only see like 2% of my patients who have passed. So like the literal dying person, like I barely see that. I only see it if it's like in the hospital and they're on life support and I'm removing it. Those are the ones that I'm truly like seeing, but I didn't know them for weeks and months. My clinic patients, when they pass away, of course it like hurts my soul because I like cared about them as if they were my own family. But I know that I made an impact in their journey that nobody else would make. And that is a gift. And that's what I'm like so grateful for. And I feel like that gives me peace. I don't think every doctor can say the same. Like, I think it's really easy to just see a patient and see them again a year later. So you don't have that same relationship. We see people every like 3 to 4, sometimes every week if needed. So you really get close to them and their families. And so whenever I do have a patient close to me that passes, I just pick up the phone and call the caregiver or the spouse or whomever it was, because you're usually close to them too. And that call can go so far. And just hearing like, hey, how was it? Like how are you? And no one's ever good, but hospice also provides like grief support. And so, making sure they're aware that there is support out there for you and, that we're always there thinking of them. I think things like that can go far. And that gives me closure. Like then it's done. Otherwise, it's like so sad, just an epic. It just says deceased. And you're like, that's it. Like that's the end of that person's life. But, you know,
Yeah. Yeah. Thank you. I love that.
of course.
Perfect. We have a few more questions left. The next question
Sure.
is from Divya.
Hi, I also really enjoyed your
Yeah,
presentation.
of
I've
course.
never heard about this specialty, so it was super
Yeah.
eye-opening.
Yeah.
My question was like, what surprised you the most when you first started working in palliative
Yeah.
care?
Hmm. I think probably that like you can learn all you want medically, like in your field, and you can be an expert in symptom management and what all the things that I'm an expert in, but you have to dedicate yourself to improving the field, like to changing other people's perceptions about what you do because other doctors truly have no clue. Like, and not even just doctors, like other people have no clue. They all think we're hospice. So, like, going into this field is a two-pronged thing where one is like the clinical side and one is the leadership and like growth of the field side. And that can be hard sometimes. That's probably more frustrating than some of the clinical aspects. I had an ICU doctor recently, and we get along so well. So I was so surprised. I had set up for a patient to, they were in the hospital, they had life support, and they didn't want that anymore, so it was all removed and he was still alive, and we had set up everything to get him to the hospice home. um, Everything was teed up. I just could not get a hold of this doctor. He has to literally put the discharge order in, and even though that's like what we had talked about on the day, he said he was on call, he was taking a nap or like some other nonsense. He picks up the phone a minute before the patient's meant to go and says, I'm not discharging him. And I'm like, we had this like horrible altercation because I'm like, why? Like, where is your mindset of not supporting the patient and the family and what they want? Finally, the family yelled at him so much that he did put the orders in. So, like, dealing with things like that when we advocate so hard for our patients and then other doctors swoop in and put the roadblock, that's really hard. And I truly never expected that. I thought, people just kind of go with the flow about what I do, but nope, sometimes people can have ego and they really have to like, you just have to work with it. But I always think everything happens for a reason. Thankfully that patient made it and they were actually live for another 5 days, but that doctor, like, that interaction has inspired me so much to like make positive change in my hospital and like share the word of what we do with everybody in a more grand way. So, at least some good is coming out of it.
Thank you.
Yeah.
Love that. Next question is from Hayun.
Hello, it's really nice to meet you.
Yeah.
I just wanted to ask, like, um, what is the biggest misconception between palliative care people have about palliative care versus
Yeah.
hospice care? Because people are
Yeah.
like very confused those two.
Everyone thinks it's the same thing. Like, yeah, I'm not ready for that. I'm
Yeah.
not ready for hospice. And you're like, they are two separate things. And that literally is why I started my social media account because I'm like, I am seeing so many patients a day and a year, and none of them know. So maybe if I spread the word online, and sometimes, the reach of social media is so broad that I'm like, even if one person learns something, it's totally worth it. But the big number one thing is that palliative care and hospice are the same. The confusing thing is in other countries, they are more aligned. Here, because we have that junction of with hospice, you cannot get life prolonging treatment. They are two separate pathways. But in the UK or in Europe, it's like very well aligned. Hospice is literally the place you go to when you're having really bad symptoms. Like it's the physical building. And you could be on hospice at home, even if you're getting treatment. But here you have to do either or. And that's really sad. Hopefully it changes someday, but like right now it's not.
Yeah, thank you.
Yeah.
The next question is from Winnie.
Hey, how are you doing this morning?
Good, yeah.
I have like less of a serious question, but like
Yeah,
you
sure.
mentioned patients wanting to like walk their children like down the
Yeah.
aisle, like
Yeah.
that kind of stuff. Do you ever receive like photos and they're like,
Oh,
look, like
mm,
we were
yeah.
able to do this, like
Sometimes, I mean, I haven't recently, like, I think the other thing in palliative care is we are totally an unsung hero. Like, nobody always remembers us in their, like, afterwards when they're like, oh, thank you to this. Like, we're often not in there. And that's totally fine. Like, I don't go into it to get that stuff. But even if there's no photos, I just truly love hearing my win stories for someone, whether it's walking down the aisle or traveling or I remember I had someone, like an older grandma with really bad lung disease or something called pulmonary fibrosis. And we gave her like steroid medication so she could breathe better for her kids' graduation. And she had like the best time. And I was so happy because, that's not what they typically do in like the lung clinic. They just kind of save steroids for an infection or like, they're just like they hold on to them. But for us, we're like, no, let's use them before your big event. And so that grandma had like the best time at a graduation. And same thing for I remember a woman with cancer with like a big old tumor right here, afraid to go to the fair. And we just like figured out ways to like wrap her up or whatever, and then gave her some medications for pain. And she went to the little fair with her kids. And those stories are, so wonderful. And like that, I don't know, it's such a gift to do that kind of work. And it's simple things, right? Like I just asked her, I didn't do anything. Like I just gave some like techniques.
yeah, that's amazing. I
Yeah,
have another question. You mentioned
sure.
you started like your own program and like your own
Uh-huh.
like clinic in some way. Like, how'd
Yeah.
you do that?
Yeah. So it was not private practice. This was through a health system. So when I was still a resident, I knew that I might want to come back because my husband was already working there. So it's all about connections. And I met like the person who hires for family medicine, and we went. They take you out to dinner. I told him what I was doing, and that I didn't even know where I was going to be a fellow yet. But nothing happens slowly, so you kind of have to like start the ball rolling early. So I was a second year resident saying I'd be interested in coming back in like 2 years. What can we do? 6 months later, he reaches out to me again. Okay, let's talk again with the person who does palliative care in our system. So now that guy came out. We had another dinner and they liked me. They were like, okay, maybe we'll set something up for you when you're a fellow. So then, like, I remember it was right around Thanksgiving of my fellowship year. And I kind of did the same with another healthcare system too. And they were like, no, we've made a position for you. We'll fly you out here, come visit, we'll interview. They set up a whole thing and they set up my job. So you have to have funding for your job. Then when I started after my fellowship, I then, built all the connections, advocated for what I want, told them like I need more people. I'm just one person. Like I need, extra help. So then we hired a nurse practitioner who I found like she was my friend. So I brought her on and we hired a nurse, a PA. Like we developed this team over 6 years. And then when I decided to move, I even found my replacement. So like I was so invested in building that program, and it's still running today, even though I'm not there. So that's also really gratifying work when you're like, that's pretty rare these days to build things, but you never know what health system is trying to expand somewhere.
Yeah, of course. Thank you.
Yeah. Mhm.
That we have over the last few questions. Hannah,
Oh,
I
I
don't
think
think
you're muted. Oh,
yeah, I don't
oh,
think we can hear you, Hannah, for
oh.
some reason.
No, do you want to put it in the chat maybe?
Yeah, we'll go to Samantha and come back.
Okay.
Samantha.
Okay, hi. Good morning. Thank you for speaking to us today.
Yeah.
You mentioned grief care, so that was making me wonder what steps do you take next after a patient passes away?
Yeah, so let's see. So if somebody is on hospice at home, then they get the support from their social worker, and usually the hospice agency has like grief support groups. So they'll follow the loved ones for 13 months because they know that the 1 year anniversary can be hard. So they'll do check-in phone calls or support groups or whatever that looks like. In the hospital, and even for my team, which is like nurses, the social worker, we have like our own palliative care team. Whenever somebody passes, we keep them on a list in Epic, and every Friday, the social worker like runs through that list, and we just kind of reflect as a group on, if that was peaceful or what could have gone better or things like that, and debrief if it's a hard case. And then we send like a bereavement card to the family, so we kind of do multiple things. We also like this is very San Diego, but one of our nurses has like a lot of shells. So like these like big shells. So sometimes we'll like write their name on the shell and like keep it in a little jar. But then I'm like you can't really do anything with the shells because it's like HIPAA, so we're just stuck with all these shells with names on it. But I even personally keep my own little bereavement list of people just so that if I'm ever like thinking about someone or wondering, I have all my lists in Epic, and so yeah, I just put like keep track of people because we're always thinking of them.
Love that.
Yeah.
Hannah,
Oh,
I
I
think
can see. Yeah. Oh, this is a great question. So this is like one of the really wonderful things in palliative care. Our work hours are great. So okay, family medicine, you might see like return patients in like 20 minutes, maybe a new one in 40 or 15 and 30 minutes. That's like 20 something patients a day. In palliative care, we get like an hour to an hour and a half with a new patient. And then a follow up might be 30 to 60 minutes. So, like, a lot happens in that time, but it is so nice to like not be stressed out in your visits. And a lot of that can be virtual too. So now when it's virtual, you gain so much time back because you're not waiting for them to be like roomed and all that. So I'll only see like 6 to 8 patients a day in clinic if that's a clinic day. Now in the hospital, it's a little different. We are a much bigger team in my current hospital. So we have like a consult list of like 20 to 30 people. I will pick up like 4 to 6 of those patients per day. And then like the next day I'm there, I'll have those as follow-ups plus 2 or 3 more new ones. So my hours are pretty nice. Like I feel like on the West Coast it's very laid back and we start at 9:30 and then you're done when your work is done. So I usually see we'll run the list as a team. I'll go see my patients. Then we all break for lunch at like 12:30 and sit together outside for an hour. Then I'll go have like family meetings or something, maybe like 1 or 2 of those with patients' families who have come. And then if get my notes done and I'm out of there by like 3 or 3:30. If a family has to meet late, of course I'll stay till like 4 or 5, but that's rare. And then I have my 25-minute commute. So yeah, I feel like my work hours are good. I go to the gym in the mornings and then I come home and shower or I drop my kids. And then I have like Tuesdays as my admin day or my day off. So that's the day I kind of catch up on life things.
I love that. I love that. So
Yeah.
so balanced. It's a balanced
Very
lifestyle.
It's very
Yeah.
important to be
Yeah.
balanced. Yeah.
Yes.
Yeah.
The last question we have is from Grace. We'll wrap it up. That's it.
Hi, thank you so much for your presentation.
Yeah.
It's really nice to see you shed light on palliative care because not so many people talk about it. And then my question was that I know that you said like different countries and states do things
Yeah.
differently. So like were there any times during like your travels like inside the US or like out of country that changed your perspective on like what the idea of good care means?
I think the biggest thing that's changed my perspective is like being on social media. I've connected with a lot of other palliative care people on social media and seeing how they function. Like people from Spain, France, Italy, like they've all reached out to me. And like it's so, even India, like seeing how things are there, but that we all face the same problem sometimes, mostly of public misunderstanding. But I think like there's pluses and minuses to everything. You know, I think nowhere is perfect. Nowhere has it figured out perfectly. I would say the UK is probably doing a better job, but I've worked in the NHS and in public healthcare. That's not perfect either.
Mhm.
You know, there's so many flaws to healthcare in general. And so I'm like, I'm just here to do my good work and spread the word. It's okay. I'm not in system policy. Like that's a whole other field. So yeah.
All right. Thank you so
Yeah,
much.
sure.
Dr. O, Dr. O, thank you so much. We learned so
Yeah,
much
of
today, and we're
course.
super grateful for your time. I think
Of
everyone
course.
had their questions answered, and we
Yeah.
just truly enjoyed learning about the field of palliative medicine.
Yeah,
And I hope
I'm so
this sparked an
glad.
interest for someone today.
Yes, I love it. And yeah, please feel free, reach out to me on Instagram or email me, like whatever you guys need. You know, I'm so amazed there's so many of you in this interest group and like you'll all do wonderful things. Just hold your boundaries, hold your space, you know, figure out what field is for you. You do not have to figure it out right now. So, yeah. All right, guys.
Thank
Thank you
you.
so
Yeah.
much.
Thank you. Yes. Okay.
Yes.
All right.
Thanks.
Goodbye.
Bye.
Bye. All right, everyone. So we're just in time for a 5-minute break. So we're gonna go ahead and get started around 10:30 for the next segment of our workshop. So do some stretches, get some water, and then we'll be back in a few minutes. All right. I hope everyone was able to get some stretches in and get some water or run to the restroom real quickly. I'm going to go ahead and transition to the next segment of our workshop, of our programming today. If anyone has questions regarding any of the topics, feel free to. I have my chat open on my screen, so I should be able to see any questions that come in, but I'll also be able to answer any questions towards the end of the workshop today. Um, I hope you all learned a little bit about palliative care and hospice medicine today. I think it's a field that is super interesting and innovating. During my time in college, I actually had the opportunity to volunteer. I actually worked as a hospice caregiver, but I have had friends that have worked in hospice, either as a caregiver or worked as a hospice aide. I think it's an experience that if you can get during your undergrad or in your high school experience, that would be it's a very transformative experience. You get to really learn a lot from patients. You also get to learn a lot from their families and kind of navigate the healthcare model. One of from a lot of student friends that I've had that matriculated into medical school, hospice caregiving and hospice volunteering has always been a stand-up part of their application. So if anyone has questions on how to get involved or, how that looks, what volunteering in a hospice center would look like, feel free to ask those questions today as well. But we're going to transition into the workshop, which is going to be kind of an intro into epidemiology and outbreak investigation. So within epidemiology and where epidemiology is housed, it's housed usually within public health. So public health is the science of promoting disease, prolonging life, and promoting health through, organized efforts and informed choices amongst organizations, public and private communities, and individuals. A lot of I didn't really get exposed to public health until I majored in it in college. But when you think of public health, what do you think of? We'd love to see in the chat. The World Health Organization. Yeah. We'll talk about a little bit about health organizations and kind of where they fall. Because I think one of the more complicated aspects of understanding public health systems for me was how does it work? How does data get from the hospital to the CDC to the World Health Organization? And how does, how are these graphs made? Who makes these graphs? Who designs these studies? And how do outbreaks when they occur? Right now, I believe we are in an outbreak for a foodborne illness right now. If you've heard, there's a lettuce outbreak going on. Who responds? And typically on that front line is epidemiologists and public health staff. And we'll learn more about what exactly that consists of today as well. One of the learning outcomes is to show you this kind of hierarchy of public health systems. So within public health, there's a lot of different areas of study. You can study health policy, where you can draft, policy legislations that promote health. The American Heart Association, for example, does a lot of policy drafting and policy, what's it called, advocacy for heart health. There's also environmental and occupational health, and we'll talk a little bit about what exactly environmental health is in a second. There's health theory, so understanding why people behave the way that they do, and we'll dive a little bit into what that means in a second as well. There's epidemiology. There's global health. So global health systems, global health. Typically, when you think of global health, you think of the World Health Organization, how they manage different large-scale international organizations and how they manage different systems across the world to ensure that they're not siloed. There's also public health informatics. Public health informatics is actually very interesting. Informatics is the field kind of study of how data flows through systems. And there are courses you can take on how public health kind of flows in the public health system. And we'll kind of talk about that today as well. But I'm seeing the chat, universal healthcare, NIH health inequities outbreak. That's exactly what public health consists of. Again, I think that a lot of students, when they first think of public health, they think of it as okay, it's just advocacy work. But there's so much more that goes into it. And if you explore that field in college, you'll get to take a bunch of different classes and get into really understanding what the system of public health is. So health theory, for example, you may be wondering, okay, there's all these different branches and areas of public health. I can show you a few of the fields within public health. So for example, health theory, for example, health theorists kind of focus on developing and understanding conceptual frameworks that explain why people behave the way that they do. For example, they address issues in different populations. For example, this can be both at the individual level, so why do people make the health decisions that they do, or at the interpersonal level. At the individual level, things are guided, for example, by the health belief model. So, for example, I'll show you this model in a second. Health belief model focuses on understanding how people perceive seriousness of a disease, how they perceive the severity of the disease, how they are like, what factors contribute to whether they're going to engage in health promoting behavior. For example, for example, malaria outbreaks, malaria is very, deadly for children, for example. So some people may associate malaria with just a slight fever. They might not understand the severity of the disease. So it's understanding how they believe health and how they believe that what risk they are at. Um, do they believe that, consequences are serious? Do they believe that if they get this, disease, or this infection, will they will they die or will they be hospitalized? Um, the health belief model also kind of includes like the perceived benefits and barriers. So, for example, if for malaria, for example, does using a mosquito net actually keep my family safe at night? So do I believe that it does or do I believe that it doesn't? So whether you believe or you have the self-efficacy or the willingness to make that change or implement that intervention is important and takes part in the health belief model. So again, you can start to now kind of visualize that if you aren't serious about the threat that may influence whether you believe that you're susceptible to get the disease and kind of influence whether you make a health promoting behavior. So understanding the obstacles that are at play is one of the kind of subset of what health theorists do. At the interpersonal level, this could also be, for example, in the community, for example, are people behaving in certain ways that others follow? For example, that's known as reciprocal determinism. So, or that's known as like observational learning, actually. So, like, if people are, if a child sees their parent sleep with a bed net every night to prevent malaria, they probably more likely do it. But if they don't, they probably won't. Some people copy health behaviors. So the social cognitive theory, which is kind of the grounding interpersonal level theory, that kind of focuses on understanding what society and what external factors influence the health decisions that you do. So that's kind of what health theorists kind of look at. And then you also have environmental health practitioners. So environmental health practitioners focus on kind of identifying what exactly impacts of different environmental exposures have on health. So for example, the physical and social and biological factors in the air, the water, the soil, the food, how that impacts your health. So for example, how much air pollution or how much particulate matter exposure are you exposed to? Um, is your water clean? Is your water drinkable? Um, for example, the Clean Air Act, which is passed in the United States, focuses on establishing kind of ambient air quality standards for like pollutants such as lead, carbon monoxide, how much exposure is won't be an adverse risk to your health. So environmental health specialists focus on developing these standards and focusing on what kind of the concentrations are healthy or not gonna result in adverse health effects. So it's kind of what environmental health kind of focuses on. Environmental health focus also is pretty, you can kind of understand environmental health through like how is it regulated? For example, a lot of times, for example, when we have, for example, when we get electricity, right? A lot of electricity when the plants that generate this electricity can cause air pollution. So typically, the payer model looks like the household will pay for the firm, which gives money to the electrical plant. But sometimes the polluters, so when pollution occurs, there are certain, legislation that these electrical plants have to follow, and if they don't, they can be billed, or they can be, they can be billed for the environmental exposure that they do. So even within the environmental health, there's the government agencies that are involved to ensure that the electrical plant doesn't, does not exceed the standards or limits on what types of specific air quality, the specific kind of like exposure that occurs in the environment. So then you have epidemiology. So epidemiology kind of focuses on how disease patterns are kind of situated within populations. And a lot of epidemiology is very data driven. So epidemiologists focus on data analysis. They take and understand the numbers behind the rates behind tracking disease. For example, during COVID-19, epidemiologists were the one that tracked the infection rates, tracked infection rates and how that resulted in hospitalizations and deaths. And they also are in charge of kind of identifying hotspots, which help target public health strategy and recommendations. Let's see if there's any questions. All right, perfect. We'll move on. So kind of how epidemiology, like the field of works and how interventions are even, proposed or recommended, you can kind of see it on the epidemiological triangle. So the epidemiological triangle is a model that's developed by public health scientists that explains how diseases spread by, examining the interaction between the agent, which is the cause of the disease, the host, which is the organism or person that's affected, and the environment. So the epidemiological triangle is really important in developing and guiding interventions. So, for example, the agent typically is, for example, like the cause of the disease. So what agent is involved? It can be a biological agent, such as, a well-known pathogen, such as salmonella. It could be other fungus or parasites that are causing a disease. It could also be chemical agents that are man-made or pesticides that's an agent for an outbreak. There can also be physical agents that can, be an agent for an outbreak. And then you have, for example, hosts. Hosts are the kind of the vector of the disease, or the person or environment, the person or organism that is affected. And the host typically, when you want to define these things in an epidemiological triangle, we try to define these different these different elements of the triangle. You want to be as specific as possible. So, for example, when you're trying to describe the host, you want to understand, for example, what demographic designation such as race, gender, or age is affected with a certain outbreak. What are the behaviors of the host? And as well as other socioeconomic factors. So when you're trying to develop interventions, you want to be very specific and tailored. So who exactly is the host? The host can't be, for example, the host city, or the host can't be like the United States of America. The host, you would want it to be very specific. For example, it could be students aged 17 to 20 in a high school, or individuals in a hospital setting in the ICU facility, so you want to have it very, very specific. And that's also with the agent. So in epidemiology, a lot of how we run is we develop case definitions, and we'll talk about that in a second, but we use elements of the epidemiological triangle to design these case definitions. So one thing to take away is when you're trying to, design an intervention, interventions can be between the host and the agent. It can be an intervention can be between an agent and an environment, and the intervention can be, for example, between an environment and host. A host and agent kind of intervention would look like, for example, a vaccination, an antibiotic. An agent and environment could be, for example, ensuring that the surfaces in food, in places that make food is disinfected. Agent environment could also be like water chlorination. Environment and host kind of interventions would look like, for example, having access to hand washing stations or access to mosquito nets. Environment host, you want to make sure that the host is as far away from the environment that allows the agent to thrive. So you can design interventions that are very specific between each ladder of each kind of section of the epidemiological triangle. You wouldn't necessarily want to make an intervention that has multiple, like you don't want to make it if you're trying to design a very specific and tailored intervention, you want to have it between two factors of the epidemiological triangle. You wouldn't want to have it between two or three, because that can be harder to lead to a successful intervention. So now I want to kind of talk about how does data move through public health systems, and how does that inform the decision making in public health strategy? So where do epidemiological staff come into play? So it's very complex. It's not there's multiple different factors and multiple different agencies and that are notified that keep the public health system alive. So For example, and I'll show you an example in a second, but this is kind of how data flows, how data is reported versus where it's notified. So, for example, you may have someone show up to a hospital that has a, for example, salmonella, or they have a COVID-19 they got diagnosed with. So after, either the hospital, or there's even like laboratories that once they test something as positive for a agent, and if it's notifiable, it is directly reported to the local and regional public health authority. And this is done through interoperability standards, which are just messages that help de-identify patients and keep everything safe within the healthcare house as data flows through the public health data flow system. So once hospitals, identified the data, or healthcare providers identify the data, or laboratories identify the data based on the state notifiable conditions, the local and public health authority is notified. And this is where kind of the first step of where like epidemiologists will come into play is they will house these databases, they'll analyze the databases to see if there's actually an outbreak and start investigating. So after, this state kind of the outbreak is kind of, identified, or it's come to the attention of the state, there could be different levels that notification may be done. So for example, certain, diseases or infections have to be reported at the national level, and some have to be reported at the international level. So then data is further transferred between the local and regional and state public health authority to the CDC, or or larger departments within a country. And this can lead to, for example, publications of, the MMWR publications, or publications that notify the public of what's going on at a national level. And then from the CDC, public health events that are of international concern can work and come to the World Health Organization. So how one lab result that you get in a hospital, how it's transferred in an international and national level, this is kind of a basic model of showing you how that occurs. So again, having one of the very, very important parts of this whole system is ensuring that the data is able to be transferred easily and it's interoperable. So a lot of times if you study public health informatics, for example, you'll understand that different electronic health systems and different electronic health records typically work in silo. So they don't work together. They don't like, identifying the data and sending it to the local, regional, and state health authority can be difficult. For example, the system that the hospital use may not be the same systems that the local, regional, state department use. So understanding how we have data that can flow easily and can allow us, again, can allow us to better understand what is going on if there's a specific outbreak, or if there's a specific area of concern that needs to be notified. So understanding how cases are reported to the local and national level and how it's recorded it's important. And it's kind of where the first step of epidemiology, where it comes into play. So I'll show another example of this because I think this can be a little complicated. So for example, a patient can visit the ER with GI symptoms such as water diarrhea, nausea, or stomach cramps, and the physician will then record it in their electronic health record. Typically they can also be in some outbreaks that, for example, like an overdose outbreak where the emergency staff has their own database that they're working in, so their own like electronic health record, and this may not be easily transmitted to the doctor, so the doctor has to write their own electronic health record. And this is kind of where I'm kind of explaining how like things can work in silo, and it's not like, oh, when the emergency staff brings the patient to the hospital, the data is transferred right away. It's not. It's typically the hospitals and the physicians have their own system that they operate in. And a lot of public health, like what is working to develop, is how we can streamline this communication of data. So, okay, patients will visit an ER, they present symptoms, the physician is then recording in the EHR, and then laboratory is going to somehow identify, for example, via blood cultures, type M testing, stool samples, they're going to identify what the pathogen is. So, for example, in this patient, salmonella was identified. And salmonella is a Texas notifiable condition. So every state and region has different notifiable conditions. I'm going to show you the notifiable conditions in Texas. So there's a list of notifiable conditions. So this is just a big list. There's typhus is on here, tuberculosis, smallpox, rabies. So these specific conditions, once the hospital system or the laboratory identifies it, they have to directly report it to the state right away. So they have to call, for example, if there's an anthrax outbreak, they have to call right away. And salmonella is actually on here. So salmonella is a Texas notifiable condition, and within 1 week it has to be reported to the State Department, and the data has to be transmitted to them. So every state kind of has their own like list of notifiable conditions. I'm from Texas, so I decided to pull the Texas notifiable condition list to show you what Texas kind of qualifies as notifiable or immediately reportable conditions. So once this notifiable condition is kind of if salmonella is identified, it'll be reported to the state directly, and this is typically through some sort of um, interoperable standard. For example, electronic lab reports are a specific standard that's transmits lab data to the state. So again, there's different how data is transferred between the laboratory and the hospital may be different, but it could be through a secure HL7 message, and these are just different it just summarizes like different languages that data is transferred. So for example, when salmonella is identified via an electronic lab report, it is sent to the state. And now the state is going to kind of respond. So this could be through, for example, developing some sort of intervention. It could be through an outbreak investigation. It could be through communicating to the public on the news, hey, don't eat lettuce right now. Or don't eat this specific brand of lettuce that was manufactured during this time period. They communicate to the public. And they also can implement syndromic surveillance systems. Syndromic surveillance systems are, for example, like this goes back to the emergency department. So they may ask the emergency department, hey, keep an eye on if there are reports of water diarrhea, stomach cramps, nausea. Like, let us know if there is, or now it's even easier because the electronic health records, some can once those symptoms are identified, they can directly report to the state. The state can flag it. So, and if a physician or provider puts on the electronic health record that someone has water diarrhea, stomach cramps, nausea, it'll flag it for the state. And then the state can follow up and see if it's associated with this specific outbreak. And once that is identified, they typically would reach out to the person that was exposed and try to understand what may have caused them to get sick with these conditions and see if it's associated with that specific strain of salmonella, for example, before an outbreak at a larger scale is identified. Again, a big role of the state and health department, especially epidemiologists, is like case investigation and how it's communicated to the public. And sometimes communications, once it's identified, there's different dashboards that the state can use to kind of show its constituents what's going on in real time. I'll show you an example of a dashboard that Texas uses. For example, for respiratory illnesses, let me see if I refresh this. The Texas Department of State and Health Services use, for example, viral respiratory deaths. And for example, if they're tracking viral respiratory deaths, I don't know if this is going to load, but it takes a few minutes sometimes. But they are dashboards that you can view that'll show you like I should take a screenshot of this instead of waiting, but let's see. If not, I'll share it after a picture of it. But there's dashboards that can be used that show kind of, for example, deaths in respiratory illness by age, or what type of viral respiratory infections are common right now, and they kind of visualize this on graphs. So epidemiologists will take that data that they receive and put it on these websites, so the people know what respiratory infections to be on the lookout for. Let me see if I can. I want you all to see this if possible. If this is gonna work. Okay, I think this is. Let's see. Okay, here you go. For example, this shows COVID-19 hospitalizations by different age groups. If you look at viral respiratory deaths, we can see that. Please load. Let's see. Oh, I can't log in right now. But anyway, this will show kind of the respiratory deaths, and I'll share an example, but it's similar to how this looks like here, for example, weekly emergency departments by age group and different respiratory infections. So, for example, as we can see in January, there was a lot of influenza, and then as we kind of got into the summer, influenza kind of narrowed out, kind of lessened throughout the year. But we'll probably see a spike again when it reaches November to January. So this is kind of the systems that are in place that epidemiologists help kind of translate to the public what is going on, and you can see exactly when there are certain outbreaks or different high kind of rates of certain diseases or respiratory infections. All right, so now we're going to look at a little bit more about what the local state health department and epidemiologists do. So, for example, we're just talking about like syndromic surveillance. So, syndromic surveillance systems, patients will, seek treatment at a syndromic participating hospital, and at any time their syndromes classify with something that is on the watch that the state health department is on the watch for, it'll notify the state and health department that there possibly is another person that with similar conditions that may be associated with an outbreak. So that's kind of how the syndromic surveillance process looks. And there's different other surveillance process, passive. There's sentinel surveillance, for example, where different counties are kind of on the watch for certain diseases, but syndromic is just an example of a type of surveillance system that are used. So when you're conducting, for example, a field investigation, so when there's an outbreak, for example, salmonella outbreak, you want to understand first you want to understand if there actually is an outbreak at all. So an outbreak is when there's more diseases of the case than expected in a given period of time. And if you use comparison data and you find that, okay, there's more cases of, for example, salmonella than there usually is, that may spark an investigation. And epidemiologists are at the forefront of these investigations. So, for example, in a field epi study, epidemiologists will first establish if the existence of an outbreak. So they'll verify data using comparison data. For example, if there is 35 people become ill after some sort of community picnic, investigators can see, okay, there's usually not this high comparing to usual times, there's not this high of spike. So let's investigate what exactly is going on. So then during their field work, they kind of gather their supplies, they develop questionnaires that they may want to, when they're talking to people that were exposed, they maybe want to have specific questionnaires. So they're going to prepare for the field work, and then they want to actually from the strain of that they've identified, they want to through laboratory testing confirm they want to verify the diagnosis through laboratory testing. And then typically they want to develop case definitions, and that's kind of using the epidemiological triangle to see what a probable case definition would be for this investigation. For example, I'll show you in a few seconds what exactly a case definition will look like, but they kind of narrow down and define what an actual case is. So for example, they want to know what the condition is. Does this have to be laboratorily confirmed to identify as a case for this specific outbreak? What time duration would this exposure would have occurred? So they develop very specific case definitions. And then they use different descriptive epidemiologic techniques to organize the person, the place, and the time. This is typically done on something called epicurves, and I'll show you an example of what that looks like in a second as well. And then after they've done their interviews, they go back to the drawing table and they okay, like, what may have led to this outbreak to occur? And then using that, they develop hypotheses, evaluate these hypotheses, and implement control measures and communicate findings to the public. So case definitions are very specific definitions that, allow public health and epidemiologists to understand what consists or what factors may associate with an outbreak. So for example, a case definition could can look like as simple as a student that attended X high school with an onset of fever and a cough between January 4th and 24th, 2007. It could also look like a visitor of South Dakota that was diagnosed by a physician, either clinically or radiographically, with a community acquired pneumonia with a symptom onset after May 1st with a laboratory confirmation of Legionnaires' disease by culture of Legionella. So again, it can get very, very specific. The clinical features, what exactly clinical features are included in the case definition. There's laboratory criteria that may be included. Typically, you want to ensure that your person, place, and time are very, very well established. So who is more susceptible to what age group should this is this outbreak kind of constricted within? Is, if at all, with where geographically is the outbreak located? For example, does someone have to be a specific resident of a county in a specific state? Or is it, for example, in a nursing home? And then time, was there a specific, is there a specific, if there's a specific timeline that that illness onset was? So this all kind of are components of a case definition. And then sometimes when you may not know exactly what the case definition may be, or there could be different types of case definitions, there could be multiple. So there can be suspected case definitions, probable case definitions, and confirmed case definitions. And then epidemiologists will also use like epi curves, for example, to show the magnitude, time trend, and outliers of specific, specific diseases or outbreaks. So you can see that, for example, this epi curve shows that on 6/23, one person was identified as a case, and then after a specific incubation period, we have this rise of cases of hepatitis A. So you can see here, okay, on 7/14 there was one case, and then on 7/21 there was 6 cases. So then you may want to kind of what's it called, focus your attention on this specific time period for understanding the cases. So you can kind of understand the magnitude and the time trend using epidemiological curves. Okay, so now we're going to do some reflection on some of the concepts we talked about. So which of the following illustrates the purpose of epidemiology and public health? All the following illustrate the purpose of epidemiology and public health except. See, perfect. So clinical practitioners are involved in providing treatment for patients in clinical settings. Epidemiologists focus on identifying populations who are at risk, addressing the effectiveness of specific interventions, and determining the importance of causes of illness. Perfect, you all got it right. The next question is, so epidemiologists use a model for studying infectious diseases, and its spread that involves a microbe that causes the disease, the organisms that harbor the disease, and the external factors that cause or allow for disease transmission. What is this known as? Perfect. So yes, this is a perfect example of the host, agent, and environment epidemiological triangle. I think everyone is getting right. Well, great. So now I want to hopefully take some of what we just talked about and provide it to another case example. So you are a public health officer working in a county. You're an epidemiologist working in a county, and you get a call about sporadic infections with specific avian influenza viruses that have been detected among dairy farm workers. So part of the first response you want to do is you want to maybe design a case definition, or you want to understand what exactly led to this outbreak to occur in the first place. So one of the tools that you may use is you may want to design a questionnaire. So questionnaires are very specific and are very tailored and what they would include is you would go to the field and identify the dairy farm workers, maybe look at the conditions that they were in and kind of understand what may have led to this outbreak in the first place. So I just wanted to also, there was a few other points in this outbreak. So this occurred in March 2024. It was a specific clade of a virus. It was detected amongst dairy farm cattle in the US, and the first case was in the Texas dairy farm workers. So after this outbreak had kind of happened, they wanted to enhance surveillance of why these poultry, they wanted to enhance surveillance and understand the conditions that people were working on in these farms to understand how this outbreak occurred in the first place and what they can do to prevent it in the future. So the tool that they used, for example, was this questionnaire. So I'll show you exactly, I've designed this questionnaire, but what this could look like, for example, is you would use your case definition. So for this case definition, they wanted people that had worked 90 within that had they wanted people within a specific time frame of 90 days that have worked on a dairy farm and cow herds and have had a laboratory infection of bird flu or HbA1 virus. So that's the first question you would ask in this investigation. So try to narrow down who you're talking to. So, for example, if the patient or the when you administer the questionnaire, if the person answers yes, then you would continue along with the investigation or the questionnaire. If they answer no, then you can end that question. You can end the questionnaire. But part of how this questionnaire was designed, they wanted to know if you had a seasonal influenza vaccine, because it was associated in the outbreak. If you read the paper, that having this vaccine helped kind of lower your rates of getting bird flu. So they wanted to understand that question. And these questions they take a long time to design. It may look simple, a simple Google form put together, but you need to understand exactly why an outbreak occurred and what factors, and you gotta kind of organize the factors that have may led to that outbreak. So you need to think about, what job tasks are done on this dairy farm that may have, caused this illness. You may want to look at, are people using the proper PPE and what PPE is available for these people at these dairy farms. So you want to ask specific and tailored questions. And when you're designing these questions, you don't want them to be open-ended. You want to try to like have them to be kind of categorical or kind of multiple choice option, because sometimes people may have performed more than one task on this dairy farm. So they could have bred cows, checked milk quality, fed the cows. They could have done a lot. So you want to have it so that you can have check boxes so you can easily, you can give this type of questionnaire and have people have multiple, they can give multiple responses. Some questions you kind of want it to be like binary. You want to have a yes or no question. So some are like that, but some are designed intentionally to be like you can choose more than one option. And then typically after, the questionnaire is administered, epidemiologists and public health staff will go back and look at the results. And in this specific outbreak, it was found that people that were in charge of kind of cleaning the milk parlor and milking cows were more susceptible for seropositive infection or having the antibodies present for HPA5, the virus. So you want to, you can once you have the data, you can use different visualization techniques to see what exactly may be the specific factor that caused the outbreak, and it can help you kind of develop your intervention or your response. So in this specific outbreak, all infected workers that were cleaning milk parlors or milking cows were significantly associated with the infection. And it was also noted that none of the infected workers were using, so the question about PPE, so personal protective equipment, none of the infected workers were using the proper respiratory protections. So that was one of the, what's it called, interventions that was given to these specific dairy farms. Yeah, so you can get a lot from doing you can get a lot from doing the questionnaire and then visualizing it, and then that can inform what intervention you're able to do or recommendations that you're able to make. Another example of a questionnaire I can show you. So questionnaires can be truly very long and they can take a lot of time. So you have to understand when you're giving these questionnaires, you got to be respectful of people's time. Here's an example of a hypothesis generating questionnaire that is used for foodborne illnesses. So there's sections for patient information, clinical information, travel. There's also questions for what type of food you prepared at home, what type of food you've engaged in within the last past 7 days. And can you imagine how hard this is? Like, can you even, I don't even remember what I had for lunch yesterday. Then now they're asking what I had for lunch 7 days ago or what food I had for 7 days ago. That's why a lot of like you can look at your credit card record. You can use, pictures that you've taken in the past to kind of help kind of organize this information. So you have to have sympathy for the person that you're interviewing, because there's a lot of information you have to get out of them for a successful questionnaire to be filled out. So, this is a 13-page question. It asks things about what eggs, dairy, and cheese, the specific brands, where you purchased it, if you had any, if you had any for this one is like what types of basil did you eat, the types of brand that are using. So it can be very, very like time consuming to get these questions out, but they're important in investigations. And this is typically what field epidemiologists will use for foodborne illnesses. And again, this would be when you're preparing for a field outbreak. So the step that I can show you again right here. So when you're preparing for field work and you're gathering the supplies, this is where you would be designing these questionnaires. A lot of health departments now have have it streamlined. So they have these questionnaires already developed. So you don't have to like create them from scratch. But again, having that and identifying which type of questionnaire you use is important, an important part of all this. So yeah, I know that was a lot of information. I think that was a deep dive into epidemiology. I think it's like part of like half of my degree in in like 30 or 40 minutes. So I know there's probably gonna be some questions. So I'm more than happy to stick around and just answer those questions for you all. I think that was the end of the workshop, but I'm also happy to share a little bit about my journey into public health before we move on to questions. I know some of you all are in high school, so you may be interested in identifying what exactly you want to do in college and what you want to study in college. I studied public health, as you can tell, as I'm giving this workshop today. I studied public health, and I also am pre-med. So I was able to do my degree plan focused on getting all my public health requirements, but also finish all the pre-med requirements, all the orgo, biochem, all that fun stuff. Um, and I think certain colleges, when I was looking at colleges, for example, I wanted a college that had a BS in public health, or had a Bachelor's of Science in public health that was kind of nested within the College of Natural Sciences. So a lot of the classes I was taking, like for my pre-med, was already aligned within the public health degree system. So I wasn't taking a lot of extra classes outside of my degree plan, to take the major. Um, so in high school, I'm gonna give you a brief overview. First generation college student. So in high school, some things that I did, I completed the IB program. And this is just advice for anyone that is in high school now, kind of what led me to now graduate from UT and get my degree in public health. So in high school, I was involved in the IB program. I also did some AP classes. I really recommend that if you have the time and the capacity to take some AP or IB courses, even if they're just a few, I think they really prepare you for the rigor of college and pre-medical coursework. Because I'm telling you, the first day of general chemistry, the first quiz, the first exam you have will be humbling. But if you have the skill sets and study skills in place, it'll make it a lot more easier. Another tip I have for those that are in high school, like complete your core classes early. This includes, for example, your histories, your governments, your Englishes, all that stuff. Try to get done early so you can get that through, college credit. So I know some people do dual credit classes where you're taking some classes at your local college, but try to get those classes done early. I say this because a lot of my university, for example, how you were placed on the registration queue was based on how much credit hours you had already completed. So, for example, and this influences what professors and classes you get. So, if you are earlier in the registration queue, you have access to more, tenured and more developed professors. Um, and this kind of helps you ensure that you're not gonna, fall behind in your coursework, or it can be harder to maintain higher grades when you're having a much difficult professor. So professors really do matter in your university when you do take it. And I think once you have a lot of core classes completed, you are naturally just ahead on that registration queue. Um, in high school, I also recommend try to take some technical education courses. I know my high school had career and technical education. We had like a honors A&P class, which I think was really helpful. Some of this material is on the MCAT. So some of the systems that you learn, I think I had a strong foundation in high school. And then you can take, for example, Principle of Health Science class. Some high schools also are really good that they have like certifications that you can take and skills that you can take. So when you graduate, you have some sort of credential. I was fortunate that my high school had a phlebotomy kind of program. So it was your senior year of high school, you were able to enroll in the phlebotomy program. You can directly get that certification when you graduate. I know some people use the summer right after they graduate to enroll in community college and get that credential. So really try your best to see if you can get some sort of credential early. This just helps to get clinical experience because when you're in college, you're not only navigating your 4 years of pre-medical education, but you're also trying to navigate extracurriculars and clinical experiences. And these are getting even more competitive and more even more important as the competitiveness of medical admissions and other STEM education admissions get even more competitive. So having those certifications are just a plus. If you're not participating, if you don't have, you're not a participating school that has, for example, a phlebotomy program, you can also, for example, get your BLS certification or your AED certification, your BLS card. Those are all helpful credentials to have when you're trying to apply trying to apply to clinical jobs in college. Um, and then in high school, I think it's also important when you're designing your application for applying to college, you have a consistent theme. I'm going to say this, there's a lot of, I'm going to just be transparent. There's a lot of like, there's stigma, not stigma, but there's a lot of like, there's a lot of information online that is designed to scare you like high school students. Like you don't have to have national awards or found something that impacted millions of people. Like you don't have to do that. I think there's a general trend right now that a lot of high school students are very scared of, okay, like you have to do all of this. I think that the less you do, but the more involved you are in what you do is more important than having numerous unrelated activities. So when I was in high school, I focused on like education and like STEM outreach. That was my thing. Like I love teaching, I love mentoring. So I was involved in, the Barbara Bush Foundation's reading mentorship program. I was involved in doing like a summer literacy camp at a local library because that's what was aligned with my passions. So when you're focusing on developing your extracurricular activities, try and definitely focus on creating a theme that will allow when you design your college application for it to all be related. You don't want to have like 10 different activities that don't kind of align together. You want to have everything kind of be natural, an extension of who you are. Because the college application is now focused on trying to find candidates that know what they want to do, but also have the experiences and the right activities that show that they're interested in what they say they are. So yes, of course, be involved in National Honor Society or be involved in your student council or be involved in other clubs at your college at your high school. But it's also important that what you are involved in, you show longitudinal involvement and growth. So this could be, for example, seeking leadership opportunities for a club that you've been in for 3 years. I know there's also a big thing about like creating passion projects, and I think passion projects are great. I had a passion project. I love what I did, and I think it helped me a lot when I went to college as well. Um, I definitely think that a passion project should be natural extension of something that you already do. So if you don't have any volunteer experience or you don't have any like you don't have like any experience in the community, you don't necessarily know what project would benefit that community. So in your ninth, 10th, kind of 11th grade, you want to focus on understanding, what resources are available in community. When you design a passion project, you want to make sure it's different from what's already kind of existing in the landscape that you're trying to create. So I think passion projects are great, but let it be more of a natural extension of who you are. I didn't like do what I was like my little passion project that I did until the summer before my senior year because I already had like the flow of how it would work early on, and that helped me kind of design a project that was very tailored to what I already was doing, and that allowed me to get support from my local library very easily, support from local teachers in my city very easily because they already knew what I was doing in the past. So I think that is kind of how you should flow on. Let it happen naturally because I didn't think I was going to do like my education initiative that I did in high school at all, but it was something that just happened naturally. So I definitely recommend that for those that are interested in starting projects or initiatives. And also apply to scholarships when you're in college, and even when you're in college for a college student now, apply early, like apply research scholarships early, like have the scholarship that you want to apply to like months in advance. You don't want to write a scholarship application the night before it's due. Like they're competitive already, like so try to identify them very early. And when you're writing, for example, your application on Common App or whatever they use, Apply Texas, I don't know, there's different portal, the UC system, you want to kind of request letters of recommendations at the beginning of your senior year or earlier. Like you don't want to necessarily want to ask for a recommendation letter in November when applications typically are due in December or early January. So try to get that done very early. And we're more than happy to help you if you want to like how do you reach out for a letter of recommendation? What do you include? You can reach out to any of our executive staff. We have experience with that. Also, when you're writing college applications, give yourself a lot of time to write your personal statement. I think I started mine in May and finished mine until like October. That was my final draft. So give yourself time. A personal statement isn't something you do overnight. Don't try to do it overnight. It's not going to happen well. You need to try and make sure it's like it's something that is a natural extension of who you are, you know? It's not something that you can create like through putting into ChatGPT. Like it's not, don't do that. Like let it flow naturally to you. Of course, you can use different systems to help you generate ideas, like and how but they need to be your own ideas. Um, so yeah, I would also just recommend 2 to 3 rounds of revision, nothing more. I don't think when you go above 2 rounds, in my opinion, your voice starts to get lost. So don't do that. So try to limit to 2 or 3 revisions at max. And we also have great team members. Ayan also, who's a current high school student. So during Q&A, you can for sure also ask him any questions um, around high school and high school, like navigating high school. But this is kind of some tips that I have. Again, you can always reach out if you have other questions. But then during college, I majored in public health. And public health sciences allowed me to very integrate my pre-medical requirements. And during undergrad, I did focus a lot on protecting my GPA. Like, I'm saying that I could have majored in biochem, I could have majored in neuroscience. Those, were great majors, and I was even looking into that when I was applying to college. But I knew I wanted to I want to take the STEM classes that are necessary to apply to medical school. I didn't necessarily want to take 3 extra math classes, 4 extra labs, and that wasn't my interest. Where my interests were a lot in like the intersection between humanity and healthcare, and that's where I found public health. So when you're in undergrad, focus on protecting your GPA. I think academic performance is very critical for medical school admissions. So if you're interested in medical school admissions, grad school admissions, your GPA, your stats matter. Again, like I know there's a shift towards like deprioritizing stats. I think stats again, if you show like a an upward trend on your stats, that's perfect. You don't have to have A starting from your freshman year. I don't think anyone had that. So protect your GPA, but also know that try and improve every year as you can. I believe people, some even medical schools, they focus on your last like 24 hours or last 36 hours of of coursework that you've done. So they kind of prioritize that. So focus on that longitudinal growth, but also focus on protecting your GPA. And again, there are people that have had lower GPA still get into medical school and matriculate, and that's normal. But I'm just recommending that like do everything you can to try and protect your GPA. I think that's the advice I want to give. And during undergrad, during your time in college, when you get there, you want to focus on getting clinical experience as soon as possible. This can be, for example, I worked as a phlebotomist, I worked as a hospice caregiver. Get those hours because those hours are very important. And that could be very like again, getting your certification the summer before your freshman year, or getting it between one of the summers between your freshman and junior year. Some certification, so also the conversation about like are certifications necessary? Like, should I get certified in something? I think it's helpful to have a certification, but there's some roles that do not need a certification. They just require that you have your BLS, for example. For example, when I was a hospice caregiver, they didn't really require me to have any certification or CNA license or anything. I just had some experience that exposed me to healthcare, and the summer campus itself helps is getting you exposed into healthcare. So when you're applying to these jobs, definitely put that on your resume. So anything that you can show that you've been involved in healthcare. So sometimes I recommend people not to even start looking for like don't even look for like getting credentialized in something unless you've already attempted to get a job without being like having a credential. So if you're someone that doesn't have a credential and you're like, okay, should I get a credential right now? Try to try and find a clinical job without that. And if you're having a hard time, then credential could be a way to go. Um, and then research experience, again, that's also an important part of the whole medical school application. Again, I'm just trying to lay out a vision for you, for those that are in high school. You can participate. When I applied to college, I was looking for universities that had great research programs. UT, for example, has the Freshman Research Initiative, which kind of helped integrate incoming freshmen into a research lab right at the bat. So that when I had that opportunity, I knew that was going to be something I would be interested in. And when you join a lab, again, during your first few years of college, it's very important that you kind of just develop the skill sets needed to be successful in a lab, and then you can apply to different programs as well. I did the Freshman Research Initiative, and then I also did an American Heart Association research program. So there are different REUs, which are research programs that you can apply to in the summer. That can be a great use of your time. We can talk a little bit more about that if anyone has questions. I did my RU through the American Heart Association. I was very particular in how I picked a lab. I wanted someone that would be able to invest time in me and kind of like, I think Davina had touched on this, like someone, a PI that was able to, that are able to invest time in you and have time for your success. So I was really adamant about having a PI that would be able to meet with me when I need to, that came off as friendly and someone I could approach. So these are all factors that you have to kind of reflect on to see what you are looking for in a PI. I also wanted to look at what research projects were going on and what I could contribute to, right? So when I chose my lab, I focused on a project that helped me eventually get a publication to that lab. So I think when you're looking for research experience and seeing what the longitudinal growth can look like is also important. And then my extracurricular involvement, you are still involved in extracurriculars in college as well. I was involved in the First Gen Longhorns program throughout 4 years. I also founded the American Heart Association Heart Club, which is an affiliation with the American Heart Association on campus. And I also served as a TA, and I served as an epidemiology TA, a field epidemiology TA. So that kind of was where my interest was in college as well. So this is kind of like the last 6 years of my life, like learning and failing and trying again over and over again as a first-gen student. So if anyone has questions on these experiences, I know there was a lot of information in an hour. I'm more than happy to stick on and answer these questions. I have about 30 minutes, so if anyone has questions, I'm going to stay on. And I think we have executive team members that are also able to answer any questions. So I'll take the first question from Jonathan.
So I heard you say that you did IB, and I
Yeah,
wanted to ask if you did the DP track or not.
I did. I did the
Okay.
diploma track. Yeah.
Yeah.
Yeah, that was very fun.
Do you have some like advice for that? Because
Yeah, so I know it's hard. It's a very complicated program. I think there's a lot of requirements, but I think it prepares you really well for college admissions and for the thinking needed to succeed in college. I actually love TOK. I don't know if you took that class yet. That was my one of my
oh
favorite
yeah.
classes in college. I took TOK and I ended up minoring in philosophy because I loved it that much. So there's different things that you learn in the IB curriculum diploma program that I would definitely take with you to college. I would also note that a lot of times you want to focus on learning in the IB program because, like, for example, my university was very bad at getting me credit for any of those classes. So you probably will eventually have to retake the classes you've already took,
Yeah.
because that's how kind of pre-med works. You need to take some of the classes again. They don't really like you claiming credit for all your classes. So focus on learning, focus on understanding those concepts because they don't go away. The biology curriculum and the general chemistry curriculum that I took IB Chem and IB Bio, they both were
Yeah.
on most of it's on the MCAT too. So you just want to develop those foundations early, and I definitely recommend um
Yeah.
doing that.
I had like a follow-up to
Yeah.
that.
Yeah.
Um, like, do you have like suggestions for like how to handle doing like all the cast projects and IAs and stuff?
CAS project. So it's a lot to manage. You have to manage CAS the hours and I think 150 and then project.
Yeah.
I was very good at diligent on my time, so I did things in the summer. I think I made the most of my summers. So then during the actual period of like classes, I was focused more on my IAs and like my
Hmm.
presentations and all that. So I would definitely
Yeah.
focus on when you're focused when you're planning your diploma program, have it so that it's designed that you aren't having all your IAs and CAS hours in this one semester. So that's what my
Yeah.
advice would be. Yeah.
Thank you.
Yeah, of course. Also, I know I didn't say this, I forgot, but if you want to hop off now and don't have any more questions, feel free to. I'm just here to answer any questions anyone has, as well as any parts of the programming that we've had so far, as well as the medical debate if anyone has questions about that. So yeah, thank you for joining the camp this week. It was super awesome to host all of you all this week, and I'm looking forward to wrapping up the program with you all next week. So thank you again. Hopefully you have some time to rest this weekend, and feel free to reach out with questions if you have any. I'm just looking at the chat real quickly to make sure. For the cold email, is it yeah, it's all the documents are going to be on our program itinerary. So on our Google Drive, our program itinerary, um, you can definitely find that. And then I think someone asked, how do I get certified? You can look through local community colleges. online courses, you probably like those type of certifications typically involve like 2 or 3 weeks of really like hands-on like you have to be in like a setting and you're doing the actual draw. But then you said there are some online courses that you can take, but you probably want to do more through community college so you can have that hands-on experiences. Um, what if my interests are really random? I think even if your interests are completely random, you can still develop a cohesive theme. I think that's like I think I also had MUN on my thing, but I was somehow also able to relate to public health somehow. I don't remember how I did it, but you can have different like extracurricular. I'm not saying that only focus on one thing. Like you can have student council, MUN, like education outreach, research. You can have that. That's for sure. Okay, that's recommended, but try to have it so it's like in a somehow made into a theme. Like making a theme is the hardest part of a college application. It was the hardest part for me. I don't even think I did it that well. But there are definitely resources online that can help you kind of think about how you should structure your application. And I don't think I put all my activities on my college application either, because some of it just I was okay, like I was doing this, but this just did not like I don't know how they would is this extracurricular activity actually benefiting my application, you know? And if I came to the conclusion that it didn't, I probably didn't even put it on map. It's been so long, so I don't really remember exactly how I made my application, but that is just yeah, that's a tip. I'll take the next question. I know there's some hands raised. Let me see. Okay, Sahar. Oh,
Thinking
okay.
I was working. I thought it was really fun to have an introduction to epidemiology and outbreak investigation. This is a really weird question, but do you think advances in technologies like artificial intelligence will like change the role of like public health
You know,
professionals?
yeah, and that's a great question. I think it'll help streamline operations for sure. Like for example, I was telling you about when you looked at, for example, um, this data flow diagram, some of it can be like some of how public health operates is it's siloed, so different parts don't speak to each other well. So I think AI has a potential to kind of streamline that operation. AI in healthcare, I think there's definitely advantages to it, but there's also disadvantages to it. And I recommend that you explore that in the medical debate if you're interested, because that's a question that we wanted to have people debate on as well. I think it's a very interesting question. I think there's pros to AI in healthcare and public health, but there's also cons to it. So I think it definitely will help streamline operations. Ayan, do you have a question or do you want to raise? I know you have your hand raised.
I had a question, yeah.
Yeah. Yes, yes.
Okay, so I'm not sure if first off, I want to start off by saying your presentation was so amazing. Everything
Oh,
was so
thank you.
organized.
I
Yes.
appreciate that.
But I wanted to say, I'm not sure if you worked in your freshman year of college, but I was gonna say, how did you like balance working and keeping up with your grades and
That's a good
extracurriculars?
question. That's a good question. You know, I did work during my first year of college. So I was I throughout all 4 years of college, I had to provide a lot for myself during college. So I had to work almost 30 hours a week, 20, 30 hours a week, almost approximately. So I did work during college, but I also worked in high school. So I think I've been working since I was 16. So I had developed that foundation of managing a lot of responsibilities at the same time. So I think that's what helped me. I already knew going into college I was gonna have to work, so I did, and I did it on the Fridays, Saturdays, and Sundays. I made the most of my weeknights every single night. Like I didn't have time to procrastinate, didn't have time to. Sometimes I was kind of sad because sometimes I didn't have time to do everything I wanted to do. For example, like there's certain elements of college that you want to experience. Like I didn't get to go to all the football games. I got to go to a few, which I love, but didn't get to go to all of them. So there's sacrifices with that as well. But you can for sure manage. I wouldn't say like I think I got my first job like in November because I had saved up enough to like survive until then. So I was like, okay, in November is when I first actually started a job. So the first few months I didn't really work a lot. I actually don't think I worked at all. I used my savings, but going into like November, December of my freshman year, first semester is when I actually got my first role. So I think you can start earlier. I think again, it's very competitive to find any like, clinical work, especially during college, because you have to be able to convince your employer that you're still an asset even if you're just working 2 or 3 days a week. But there's definitely like if you're in big college towns, this is why I also recommend being in like larger college towns if possible. Like I went to UT, so that was in Austin, Texas. So there was a lot of like opportunities was pretty much like really not as hard to get if I was not if I was in a smaller city, for example. So going to college, for example, going where you go to college also I think should be a factor when you're trying to make your decision. But I knew like I knew in Austin there was a lot of like there's like big like healthcare systems there as well as very like they had a lot of like they had one of the places I worked was in hospice caregiving. And I had known about that opportunity, so I knew it was on my radar when I was applying and looking to colleges. So I think knowing where you go and is important, but also knowing what resources are housed near where you go is also as equally as important.
Okay, perfect. Thank you so
Yeah,
much.
of course. Hannah, I'll try to keep my answers concise. 'Cause sometimes I go on rambles, so I'm sorry about that. Hannah, yes.
Thank you so much for your presentation. It was really, really organized, and I liked how you walked us through like all the steps and everything in public health. So this might kind of sound like a stupid question, but you
Yeah.
know how like you walk through like all the steps on like how like health organizations like handle a specific like scenario and things like
Yeah.
that.
Yeah.
So is that only for like health organizations like in the US or like locally, or like do all health organizations like around the world, like do they all go through the same steps and process?
Yeah. So that's a great question, first of all. So a lot of what I focused on today was more like the US level, and the level of Texas. I think there's some great like replicable factors that other countries and state may be using, but even to the state it differs. So local state health departments, regional health state departments, national level state health departments, they operate like a little differently. um I would say the general reporting trend would be pretty similar. Maybe hospitals record to maybe a larger local national authority, which then reports it to, for example, the World Health Organization. It all usually comes back to like big international concern and outbreaks, comes back to the World Health Organization. So even if, for example, in Rwanda, they have their own systems of reporting and notifying that leads to eventually it being reported to larger healthcare organizations such as the World Health Organization. So it's very different. I think like in Texas, for example, we have notifiable conditions. For example, salmonella is a notifiable condition. Some states may have different outbreaks that are considered notifiable. I think salmonella is pretty like throughout the country, it's notifiable, if I'm not incorrect, because even like the CDC has their own it's called the Food Net system, which will like track these specific agents of disease. So again, on the international, but everything you want to work together, not in silo. Like you want these systems to be interoperable. That's the term we use. You want these systems to be interoperable. You don't want them to like not work together, because when they don't work together you may have like, for example, like a lot of epidemiology, a lot of public health sciences may be delayed. If you have an outbreak for example, typhoid fever or rabies, you don't probably want it to take 1 month to get to this national or the state health department, right? You want it to happen pretty quickly. So how data is transmitted, also like how fast data is transmitted, it can like vary state to state, but most of the immediately notifiable conditions are pretty standard in my opinion. Because, for example, rabies, you want that to be identified pretty quickly so that appropriate intervention is taking place. Because time is on the line. Yes. Yes.
Thank you.
I think you're cutting off a little bit. Okay, yeah. Okay, yeah, of course. Matthew.
So I was just like wondering in college, would what would you suggest like your academic path be? Because like, would you want to have like more rigorous subjects that could like have a possibility of getting you like a lower grade, or should you try to aim for like slightly easier classes that can get you
You
A's?
know, that is a question that a lot of people like it's a question of debate that is common. Personally, I would focus on what is interesting you. Me, public health was something I identified early on, was something I really wanted to learn about. So I took it. And yes, there's some classes that, I'm taking that are probably a lot easier than something a biochemistry student would take. But also how your college application is identified, how when you apply to medical school, for example, they're looking at your GPA and they're looking at your STEM coursework. So for example, for me, like I took all the general chemistry, I took the physics, I took the organic chemistry, I took the biochemistry, I took all the labs and all that, you know. So when my science GPA is evaluated, that is the number that they're looking at. So typically, like medical schools will break down into your cumulative GPA and your science GPA. Like your science GPA is what matters. You want to protect that, you know. So for me, like I had those rigorous classes were the ones that like were my science GPA, you know. And since I was able to pretty much do really well in those classes, that science GPA was really high. You know, if you take additional coursework, that may influence your science GPA and it can help, you know, pad it out. If you take a major that, for example, neuroscience, you may take a lot more science classes that can may help pad out that science GPA if you're kind of, you know, if you're kind of if you're having a harder time with some of those other like pre-med requirement courses, you know? So I think there's not like a one right major to take. And, you know, if you look at medical school websites and the requirements for application, they want you to explore something that you're passionate about, but also complete the prerequisites. I've had people major, like I have a friend that's majored in business. I've had friends that have majored in English, people major in the arts, like, but they still complete all their pre-med requirements. And I think that helps you stand out a lot in the application process as well, because you're not like a typical cookie cutter. People say cookie cutter pre-med. I don't think there's a cookie cutter pre-med, but people will say that. But you can just find something that you're interested in and follow that. That's what my advice would be.
Yeah,
Okay,
I'll add
thank
to
you.
that too. It's like I would say like do a mix of things. Like not all of your classes need to be like super, super hard. Like you should challenge yourself with like a few hard classes just so you know what it's like eventually to like work your way up to taking grad level classes in medical school. Um, but yeah, it's okay to do a mix and then also like do like Ahmad was saying, do what works best for you and what brings you joy in college. I did an architecture minor, like just for fun, because I had so many like different science classes and I felt like I was gonna go crazy if my entire schedule was just science. And that genuinely made me happy. And I did well in my architecture classes. I'm also a non-traditional student, so there were some classes I didn't take in college that I had to take after. And when I took them afterwards, I made sure I did really well in those classes because they were like prerequisites for medical school. So yeah, find a balance. And it's okay to have like a couple of easy classes in there or to try and find classes where you know the professor is going to teach well, like you want to do well and learn well in the class to the best of your ability.
Do you have any other advice? I forgot that you're here. I would definitely have looped you into some other questions. Like generally, like that is how you would when you're looking for majors, you would want to pursue something that you're more passionate about rather than following a traditional path where a lot of people just follow, right? Like you would want to focus on finding what you're passionate about.
Yeah, I would say so. But like equally too, I had friends like I think I have a couple of friends in med school that like also did typical majors. Like
Yeah,
one
for
of my
sure.
friends did a biochemistry major. Like
Yeah.
that's totally fine. Like just don't feel like you have to do something just because someone else said, "Oh, you should major in biology or you should major in English so that you look different." Like do the major that is going to make you happy because you have to take the prerequisites anyway. There's lots of ways to demonstrate that you're a unique and holistic applicant. It can be through your extracurriculars, it can be through your major, it can be through whatever you do in your gap year after college. But everyone's path is going to look a little bit different.
Completely agree. I second that. Yeah, everyone, there's not like one application that is the correct way to do it, you know, and there's not going to be like, you can't, like, if, for example, you had a friend that if you follow the same exact things that they did, that doesn't necessarily, that doesn't necessarily mean you're going to get into medical school. Like, there's so many different factors at play, and that's just how it works. And it's kind of sometimes frustrating, but that's why the whole process focuses on trying to develop who you are and explore your own interests. So that's the advice I would give. Thank
Okay,
you.
thank you.
Yes, Lucas.
Hi. First of all, thank you for giving us such like a comprehensive window into public health.
Yeah, of course.
Um, I just wanted to ask, in terms of getting your certifications for all those like volunteering roles,
Yeah,
and like work roles in university, I know you probably did them in like high school, um,
yeah,
but like I know a lot of local colleges in my area, don't really offer summer courses for them. You have to take
yeah.
them in conjunction with the school year. So I was just wondering, how did you balance all of your, extracurriculars and your courses and that extra coursework?
Yeah, I think it was hard. I think for me, senior year was really hard because I was managing college applications and I also was enrolled in the phlebotomy practicum courses. Again, I try my best to manage my time through a planner or Google Calendar. I think that was really helpful. I think again, if your local like college or high school doesn't offer like a credential, and that's also okay. Like you can get, and again, I want Tamina's input on this. Like you can still get clinical roles and clinical involvement without directly having any certification, correct? Tamina?
Yeah,
Um,
like to some degree too, like there's so many factors at play because like applying to medical school or just any grad school is like so competitive, but also like there's a contextual understanding when you're applying to college, when you're applying to grad school, that you have access to the opportunities that are near you. Like, especially if you're a high school student applying to college, like colleges are going to look at like what zip code, what like kind of
Yeah.
state you grew up in because they know education and resources are not equal across all of the states. So that's something to consider. But at the same time, also like I get the pressure of like, well, I want to make the most out of the opportunities that are near me. Um, Something I think something I wish I looked into when I was like in high school is maybe volunteering, for example, for like a hotline crisis or crisis line volunteering, because I did that in college. But I feel like that's also a skill you could learn in your later high school years. And that was a meaningful, like clinical, I need to look up technically if it counts as a clinical experience or not, but I got to talk to actual people over the phone and they would tell me how they're feeling, how they're doing. I was trained to help people handle like mental health crises and like identify different issues. And that was still a meaningful experience, and I didn't have to like go and take someone's blood or anything like that. Also for me, I didn't get a lot of my clinical experience until like I was in college or after I graduated college. And like that's okay too. Like just sometimes you need certain qualifications before you do things in your area. And that's also fine. And there's also other ways, like medical schools and schools in general are also looking for you to like there's something called like soft skills, right? Like that you can transfer between things. Like you can, for example, volunteer at a nonprofit over the course of several months or several years where you get to interact with people. Like those are still meaningful experiences. They
Right.
not might not be like strictly clinical, but you're developing some of the same skills that you will need in a clinical setting, if that makes sense.
I am a big fan of that response. I think you definitely need a balance between clinical and non-clinical experiences and being out in the community. Being a tutor, for example, I know that's a great way to just help other people and just be involved. So there's different avenues you can take, but that clinical roles I think are very important, but also focusing on roles that are clinical adjacent, for example, are great. So thank you for that advice, Tina. I'll take the next question from Yukta.
Thank you so much for your
Yeah.
presentation and also like your advice for college and high school. And my question was like, how did you like find like hospice, like the volunteering
Yeah.
opportunities like near you?
So I literally would look up on Google. Like that's how simple it was. Like I literally would go on Google and say, like, for example, hospice aid or nursing aid near me. Or like I would go on my university had Handshake. I don't know if I think most colleges have Handshake, I think now. I think there's like a specific job portals for college students in that specific university. So I was on there one day and I was applying to different clinical roles and I found a hospice caregiving role at a facility that specifically focused on people were diagnosed with HIV. And I applied to that role and I got it. And I think was a very, very like I think monumental experience for me because not only did you help were involved in the clinical sides of it, but you were also involved in helping design and curate meals for residents with different conditions and stuff. So I think when you look for a hospice, for example, you can literally just look it on whenever you're in like even now, like go on Google, find 5 or 6 different hospice facilities near you or different facilities near you and just send a quick email to them to see if they accept volunteers. I think a lot of I think volunteering in hospice is a very common experience that people do, but I think it's a very great experience if you can if you can get involved in it. But it's not as complicated. Like, it wasn't any like
Thank you.
yeah, it wasn't anything like I like had a network where I had people. I literally was just me and the computer and applying to different places and on Google. Like that's all it was. Like had no network to get those jobs that I had. So I would say just apply and practice your interview skills because a lot of these places will have like interview skills and they'll have some crazy questions like how would you deal with XYZ situation or stuff. So definitely before you go into any of those roles, practice and hone on your interview skills. I think that's very important. For Hannah?
Hi, thank you so
Yes.
much for the lecture, and I'm really sorry for taking your time. I just
No,
wanted
of
to
course.
ask, like, for students from countries where opportunities like EMT certification, clinical volunteering, or other structured extracurricular programs aren't available, what are the best ways to demonstrate initiative and prepare for a future in medicine? Because, like, I'm personally from Bangladesh, and there's nothing we can do, like, to show our initiative or like get involved in a way. So yeah, I wanted to ask that.
Yeah. So I would say see if there's like local nonprofits that may be able to provide you like some hands-on experience. I know internationally it's a lot different than how things operate here in the States, for example. I would say look for example, local nonprofits that may be doing work that you're passionate about. For example, there's a lot of nonprofit organizations that work to, for example, reduce maternal mortality or work to increase access to medications in a certain part of the country. Like seeing if you can get involved and tap into those networks is where I would first start. Timmy, would you have any advice for people that may
Yeah.
want?
I we also messaged earlier and I like sent some suggestions, but um I'm trying to think too, like there's if there's any like Bangladeshi American nonprofits that take like remote volunteering. I'm genuinely not sure. But since Ahmad, since you mentioned the word nonprofit, I might look that up because
Yeah.
there might be some, honestly.
Like,
But yeah,
yeah.
definitely look at nonprofits near you. That's a
Nonprofits,
good suggestion.
that's a yeah. I've heard of people like especially people in the Medicine Power program. They've looked at like and they've volunteered and worked at nonprofits or like specific initiatives within nonprofits. And this can also be virtual. I know there's our nonprofit operates virtually. There's so many virtual nonprofits that you can work to get some experience. I know there's like for example volunteer you can volunteer time to for example the crisis line. That's a great way to volunteer online and I don't think you have to be any there are different crisis lines in different nations but you can look into that but also you can see if if there are local nonprofits that may be able to provide those kind of adjacent experiences.
Okay, thank you so much.
Yeah. All right, now that was a lot of questions and I'm more than happy to stick on for a few more minutes if anyone does have any other questions. I know there was a lot. I know we went through epidemiology, we went through like a lot of the pre-health, pre-med stuff. But if you ever have any questions, our team is more than happy to answer questions for you on Slack. You can reach out to Mina, you can reach out to me, Davina, really anyone on our team. Ayan is a current high school student, so if you have specific questions on what he's doing, for example, to what he's doing in high school now, I would definitely reach out to him. He's a great resource. So, all
Yeah,
right
and
then.
feel free to post
Yeah.
in the questions channel too if like you want to see what different interns say.
Yeah. 'Cause we all have very different journeys, right? Like we all have had very different experiences and that have led to different roads. So I think this was exactly I wanted to share what I did necessarily, but there are different. Everyone has their own way of navigating. So, well, thank you all, and we'll see you all